that decreased flowing produces a diseased body and brain, that is a big thing to that man. Multiply that sick man by 1,000, and you control the physical and mental welfare of a city. Multiply that man by 1,000,000, and you shape the physical and mental destiny of a state. Multiply that man by 130 million, and you forecast and can prophesy the physical and mental status of a nation. So the slip or the fall, the subluxation, pressure, flow of mental images, and disease are big enough to control the thoughts and actions of a nation. Now comes a man, and one man is a small thing. This man gives an adjustment. The adjustment is a small thing. The adjustment replaces the subluxation. That is a small thing. The adjusted subluxation releases pressure upon nerves. That is a small thing. The released pressure restores health to a man. That is a big thing to that man. Multiply that well man by 1,000, and you step up the physical and mental welfare of a city. Multiply that well man by 1,000,000, and you increase the efficiency of a state. Multiply that well man by 130 million, and you have produced a healthy, wealthy, and better race for posterity. So the adjustment of the subluxation to release pressure upon nerves, to restore mental impulse flow, to restore health, is big enough to rebuild the thoughts and actions of the world. The idea that knows the cause, that can correct the cause of disease, is one of the biggest ideas known. Without it, nations fall. With it, nations rise. The idea is the biggest I know of. Who wrote that? E.J. Palmer wrote that. Welcome to session 3 of the basic 100-hour course. Merry Christmas. And after the class tonight, I'm going to buy all those interested a Christmas drink at the bar across the street at the Westin. So that'd be after we finish class tonight at 6 o'clock. So if you're interested, I will buy the first round for whoever wants to come. Okay? We'll spread a little Christmas cheer. Now, let's see, where's San Jose? So last time, we had, where's everybody? Just late? You're going to come in late? Is that what it is? Okay. Is it finals or something, or is it graduation, or finals and graduation? Okay. Graduation down south and finals up here? Okay. Well, finals are important, but this is more important. This class is going to teach you have to pass your finals to get through school, so definitely do that. But this is what's going to teach you how to get your patients well and keep them well. That's what's going to build your practice. It'll be good for you, it'll be good for your patients, and it will be good for your profession. Now, last month, as we continue building our paradigm that there is cause for everything that happens in the body, and we had talked in detail about blood sugar and the adrenal glands, and we learned that there are basically 2 types of hormones. The cholesterol-based hormones are from the adrenal cortex, and I guess for Christmas I should use red and green, so that's what I'll do. And but basically, the adrenal cortex produces the cholesterol-based hormones, and cholesterol is made by the body 75 to 80%, and only 20 to 25% is taken in exogenously. From cholesterol, we get pregnenolone, which requires niacin as a cofactor. From pregnenolone, we have 2 pathways, either to progesterone or to DHEA. From DHEA, we get testosterone. From progesterone, we get testosterone. That requires vitamins A, C, E, and the mineral zinc. Zinc is the most common mineral deficiency in the United States today. From testosterone, we get estrogen. That requires vitamin E. From progesterone, we get cortisol. That requires vitamin C, vitamin B5, and folic acid. Who named vitamin B5 pantothenic acid and coined the phrase biochemical individuality? Roger Williams from the University of Texas. From progesterone, we get aldosterone, and that requires niacin. So that's basically how it breaks down. It's not my fault. I didn't design it that way, but that's just simply your physiology. And realize that cholesterol is very, very important. You're going to die from just one of three things on the average in the United States. One is cardiovascular disease, two is cancer, three is medical doctor. That's according to the New England Journal of Medicine. And it's a sort of a U-shaped curve. High cholesterol is associated with cardiovascular disease, but low cholesterol is associated with cancer. So you don't want high or low cholesterol. You want a balance in the body. And if you have high cholesterol, you want to check for low thyroid, primarily, maybe not breaking it down properly by the liver. Either they're consuming too much or they're making too much. Now, these are the cholesterol-based hormones. The mineralocorticoids, or the pro-inflammatory, that's aldosterone, is the primary one, and that controls salt and electrolyte balance in the body. You can get dehydrated even if you're drinking enough water, because if you're not producing enough aldosterone, then you don't get sodium reabsorption at the distal renal tubules, so the water just runs through you. The glucocorticoids, of which cortisol is one, are the anti-inflammatory. Cortisol helps to raise the blood sugar up, and it's the level of cortisol that is more responsible for bone health, much more so than estrogen. Also skin health and many other things in the body. We'll talk more about that when we discuss the pineal gland in session 7. Also cortisol is produced there as well. Then we have the sex hormones, progesterone, estrogen, and testosterone, as well as DHEA. And you're very familiar with those factors as well, I'm sure. So those are the cholesterol-based hormones. Now, if you have pain, for example, over the annular ligament, and external or supination takes the pain away or reduces it, what do you think of checking? The cortex factors. The cortex factors. And if you have pain, for example, over the annular ligament, and pronation or internal rotation takes the pain away or reduces it, what do you think of checking? The medulla factors. That's coming from David Lee. So besides the cholesterol-based hormones, we also have the tyrosine-based hormones, and those produce the catecholamines. I don't think that's going to help the people in the back because I think it's too small, but we'll see. Okay, from phenylalanine we get tyrosine. This is all reviewed, so I'm going rather rapidly. From tyrosine we get norepinephrine. Remember, adrenaline is the term that Park Davis used. The real term is epinephrine and norepinephrine. And from norepinephrine, we get epinephrine. Okay, this requires what? B12, a methyl donor, zinc. This requires B3, B6, folic acid, vitamin C, tyrosinase, and copper. Okay, primarily. These are the catecholamines. These are the tyrosine-based hormones from the medulla part. And remember that the adrenal medulla is a neuroendocrine transducer. That is, from direct nerve supply, hormones are produced. So we don't get tyrosine primarily from fruits and vegetables. Those are from our protein foods: beef, fish, chicken, turkey, pork, lamb, and eggs. And we need those absolutely to be healthy. What I see in general with women is protein deficiencies. Men eat too much fat in general. So if you're going to have your, girls, if you have your Caesar salad at lunch, have it with chicken or salmon or beef or something. Put that protein in there as well. Make sure you get your protein in for the day. Okay? Now, sugar, I think, is a bigger problem in this country than is AIDS or anything else that they're talking about currently, because it's socially acceptable. And so many people eat so much of it. The American Diabetic Association has just recommended that diabetic testing be lowered from 55 to age 35. The average U.S. citizen eats over 150 pounds of sugar a year. So increased sucrose, remember that all starches, bread, pasta, rice, and potatoes, turn to a disaccharide called maltose as soon as it hits the salivary amylase in the mouth. So we also want to get off bread, pasta, rice, and potatoes. And dental caries, decreased immune system response, increased trigs and cholesterol, increased blood insulin levels, uric acid levels, body fat, calcium excretion, gastric acidity, blood pressure elevation, malnutrition, platelet stickiness, and many other things. This list is not all inclusive, but it'll give you some idea of just how bad this stuff is for you. So we can't fix the adrenals without fixing the blood sugar. So I tell all my patients universally, get off sugar. Pies, cakes, cookie, candy, ice cream, soda pop, donuts, brownies, no bread, pasta, rice, or potatoes. Eat protein with veggies, beef, fish, chicken, turkey, pork, lamb, and eggs. Eggs are fine as long as the yellow is runny, with vegetables, any kind you want except potatoes. And eat fresh whole fruit in between your meals. You can mix your fruit, but don't mix your fruit with anything but fruit. And have oranges, not orange juice. Have grapes, not raisins. And if they change their diet, miracles start to happen. Just from that alone. Just from that alone. But it works really well with the structural and the emotional and the supplements. But just changing the diet, just doing that, you'll be surprised what happens to so many people for so many things. Okay, now we had also discussed cranials, and what is the center of cranial motion? The sphenoid, which articulates with 12 other bones. Cranial movement is not an opinion, it's a fact. First documented in 19... What? Viola Fryman, by hooking up a measuring rope with transducers to a plethysmogram and a pneumogram, and that was in 1963 was the first year that she documented that. Okay? It was published later on, but she first did that in 1963. Now, since then, many other studies have been done. But let's review how the cranium will move on normal motion using the tip of the mastoid as a reference point. And we're going to talk about inspiration, because if you know inspiration, then you know expiration is the opposite, don't you? How does it move on inspiration using the tip of the mastoid? It moves posteromedially, and the squama of the temporal bone flares laterally like the gills of a fish. And realize the iliac bone moves the same as the temporal bone. So using the ischiotuberosity, it goes posteromedially, and the iliac crest flare laterally. Okay? Now, what happens at the spheno-basilar junction? That goes into what? Flexion. Like you're putting your thumbs into a grapefruit. So it's flexion at the spheno-basilar junction. We also have flexion at the apex of the sacrum. The tip of the coccyx moves posteriorly like a hinge joint. Okay? These are definitely on your exam, and you definitely need to know this stuff. Okay? What happens at the matopic suture, the frontal bone? It goes internally. What happens at the sagittal suture? It spreads apart. Okay? That's just normal cranial motion on inspiration. What happens at the appendicular skeleton? It goes into external rotation. Right. Okay, any questions on normal cranial sacral motion? Okay, that you should know real well. Okay, now, how do we correct most cranial faults or lesions in applied kinesiology? With or against normal cranial motion? Against both. Okay, and when there are exceptions, I'll point those out to you. So, for example, last time we learned primarily the flexion extension group. Remember, there are three groups: flexion extension, rotational, and sutural faults. So last time we started with the flexion extension group, and if we have a weak muscle that strengthens with the patient's breath held in, what is that? It's an inspiration assist, and we're going to push P to A on the mastoid process, or P to A in lateral, or P to A in medial. And as the patient breathes in, we're going against normal cranial motion, we're loading up the reciprocal tension membrane, and the correction is made when we let go. It rebounds into correction. Okay? Where do you therapy localize? This is mainly academic, but where would you therapy localize for an inspiration assist? Keith? Carla? At the occipital mastoid suture. That's a diplomate question. And where would you have palpable pain? Keith? I'm going to pick on Keith today. Where would you have palpable pain? A mid-pupillary line. Okay, that's for inspiration or expiration. That's like mainly academic type stuff. Okay. Did you challenge for an inspiration assist? Sure, yeah. And how does it challenge? On a rebound basis, just like the spine. Okay? So you could challenge on the mastoid to find the vector and then correct in the challenge direction. Okay? We all okay? We all here? Okay. Now, an expiration assist is a weak muscle that strengthens with the patient's breath held out. That's an expiration assist. And we would push A to P on the mastoid, or A to P in lateral, or A to P in medial, depending upon how the vector challenges. Okay? And the therapy localization and the palpable pain are the same for inspiration or expiration assist. Okay? Now, an exaggerated spinobasilar, or an exaggerated inspiration assist is known as a spinobasilar inspiration assist. And that's a weak muscle in the clear that strengthens with the patient's forced breath held in. Okay, so now we have a weak muscle, patient takes a breath in, doesn't strengthen, but that strengthens the forced breath held in. And it's the cranium is stuck for an extension. So what we need to do is we still push P to A on the mastoid, but we add another lever on the hard palate, being careful to stay off of the cruciate suture, and we're simply doing two motions at once as the patient takes a forced breath in. So, okay? It's an exaggerated inspiration assist, basically. Okay? Many times, headaches behind the eye be a spinobasilar inspiration assist. A hypoendocrine situation like hypopituitary or hypoadrenal. Category 2. Sometimes also a disc lesion. Okay, now, spinobasilar expiration assist is the same thing, it's just an exaggerated expiration assist. That's a weak muscle that strengthens with the patient's forced breath held out. So we're going to push A to P on the mastoid just like with an expiration assist, but now we're adding another lever. We're going to push on the hard palate, P to A, being careful to stay off the central incisors as the patient breathes out. So it's So we're using two levers and all the same indicators, except that this would be more for a hyperendocrine situation, like a hyperpituitary or hyperadrenal, that type of thing. Hyperthyroid, where you need to tone it down. Very often you'll find a spinobasilar inspiration assist on one side and a spinobasilar expiration assist on the other side. You'll find that very often, especially in patients who are switched, which is an old term that we used to call neurologic disorganization. We'll talk more about that in session 4. Now, we went over all the sutural faults, but we especially went over the sagittal and the cruciate suture. And how would you challenge for any sutural fault? What are your 2 options? It's either jammed or it's separated. That's the only 2 options you have with a suture, right? So you're going to challenge together, you're going to challenge apart, you're going to go in the challenge direction on the phase of respiration that negates the challenge, right? That's for any sutural fault. Remember, we kind of beat that like a dead horse, okay? We kind of went over it. So we challenge together, challenge apart, go in the positive challenge direction on the phase of respiration that negates the challenge, okay? Now, with the sagittal sutural fault, there's a particular muscle group you'll find weak. And this is one exception to the general rule. The sagittal suture is nearly always jammed, and you always separate on inspiration. But what is that muscle group? Weak abdominals. Weak abdominals. Allowing the separation of the xiphoid and pubes, very often creating a lumbar facet syndrome. Okay? So, any questions on sutural faults? What's the first cranial fault you should check for if you're going to do the cranial? The cruciate suture, because if it's locked, it'll lock the entire cranium. We challenge apart, usually apart, and find a breath in or a breath out that negates it. And you start in the middle of the suture, work your way back, and then come forward, separating it usually. Okay? And you'll have palpable tenderness in the masseters and the mid-cervical extensors when you have the jammed suture. Okay? Any questions on the cruciate fault? First one you should check for is the cruciate. Any questions on sutural faults in general? We have coronal, sagittal, amboidal, cruciate, squamous, zygomatical temporal, zygomatical maxillary, zygomatical frontal. Okay. Palpable tenderness for the cruciate suture. You'll have tenderness, this is in your handouts from last time, in the masseters and the mid-cervical extensors. Okay. Now, if the shoes don't move and the dude don't groove, then according to Isogai, the Japanese researcher, we walk on an average of 6,000 steps a day. When we jog a mile, it's about 1,000 strides. And if you look straight ahead and step forward in a gait position, certain muscles should turn on, and reciprocally, certain muscles should turn off. If I have my right foot forward, which upper trap should be conditionally inhibited? The right. I kind of thought I would look it up. Remember, it's always the upper trap on the forward leg side. Which SCM? Opposite. Okay, if you learn anything out of this class, just learn that. Okay, please. Now, that's the upper half of gait. What about the lower half of gait? That was based on the work of Fred Illy, a Swiss chiropractor who did a lot of research at the National College of Chiropractic. And if we check if I step forward on my right foot, my right ilium comes forward, but the right piriformis is inhibited, that allows the right sacrum to come backward, and the TP of L5 goes forward with the ilium. So it's sort of this motion in space. And if we test the piriformis weight bearing, it should be strong, but when we place the hands in a gait position, that should test weak. Okay, that's just normal neurophysiology. Okay, so that's the lower half of the gait, and we have the upper half of the gait. Okay, what if they're not working properly? What would you do to fix it? How would you find it?
Therapy localization.
Right, use your tool of therapy localization. Where would you look first? Right, look to where the dura attaches. The dura is firmly attached to the periosteum through the sutures in the skull, to the occiput C1, C2, C3, to S2, and then through the primary terminal to the coccyx. But you basically therapy localize here, then here, and then to correct or to check the cranium, have a mic or open wide. The TMJ muscles, the upper trap, and the SCM are the primary muscles that move the cranium.
Notice when you were demonstrating a TL of the ability to use the back of your hand, is there a preference for the back or the hand?
Is there a preference on TL to front or back of the hand? There's no preference. It should therapy localize palm up or palm down. Now, sometimes it'll only therapy localize palm down or palm up. There's a reason for that, which we'll get into at session 6, when we talk about ionization and alternate nasal respiratory patterns. But for right now, to keep it simple, just sometimes you may want to check it this way or that way. It could be palm up or palm down. But you'll learn why in session 6. There's a reason for that. You'll learn how to correct it then. Okay. Any questions on gait, upper or lower? Now, people walk, but people also bend. And according to Fred Illy, when we bend either 30 degrees in flexion or 15 degrees in extension, the right piriformis, this is according to Goodhart, but according to Illy, the spine has to rotate in a clockwise fashion. Goodhart found the right piriformis iliacus, left lap, left upper trap, right SCM should be inhibited in 30 degrees flexion or 15 degrees extension, okay? And if it doesn't work, what do? Anybody out there? Use your tool of therapy localization, and where do you look first? Where the dura attaches. Anybody been studying the last couple of months? Anybody been practicing the last couple of months? Anybody been a bad boy or girl this year and not been practicing? Okay, can you get a coal in your stocking? All right. So that's a good place to start. Check for upper gait, check for the piriformis gait of vision, check for the bending via the plus mechanism. And you got handouts and all that, didn't you? Okay, I know you did. So that's all written down for you in a flow chart fashion. Okay? All right. Bruce, does somebody else know how to work that equipment besides you very well? Does Rob know how to work it?
I think John does.
Okay, come on up, Bruce. Take your watch off. Now, just walk again. Move that one chair in, Ryan, on your table. And somebody move their backpack in. So, okay, now Bruce, you're thinking. Don't think, just walk. Okay, now turn around and walk faster. Now, how does that gait look? Not too bad, right? Not too bad. Come on up. I don't see any major thing there. Nothing major. Okay, come on over here. Face that way and step back a little bit. Now, when you test the upper trap, bring the ear and shoulder together, chin towards me, eyes open. That's actually weak in the clear, so can we check his gait? No. Bring your head all the way down, all the way left. Push hard here. That's weak in the clear. Bring your ear and shoulder, hold real hard. That's weak in the clear. Are you trying? Head to the right. Push hard here. That's weak in the clear. We can't check his gait, can we? Oh. Looking for a wall we can use. But, okay, come on over here. And could somebody just stabilize the back of that podium? Anybody, Rob? Or, and come on over here, Bruce. Lean up against that and let him just hang. Now, bring your knee up. When you test the piriformis weight bearing, make sure that the femur is parallel to the floor. Now, I'm going to push out, you push in. Bring your left, now that one's strong. Bring your left arm up, right arm back. Is that what it's supposed to do? Yeah. Now, bring this one up. I'm going to push out, you push in. Bring the left arm up, right arm back. Isn't that what it's supposed to do? Yeah, it says that's pretty good. So the lower half of the gate is working. The upper half we can't check because his upper trap and SEM are weak in the clear. Can we check his plus? No, we can't either because the left upper trap is weak in the clear. When you check the plus, make sure you check it standing and sitting. So let's check him sitting. Next. You have a seat here, facing that way. When I do this seated, I always have the palms up. Why? So they won't push down on the table when you go to tap them. Bring your ear and shoulder together. No, that's still weak. Now, open your mouth wide. That's still weak. Bite down hard. That's still weak. Okay? Now, where would you go from here? We would question him. What do you do when you have a weak muscle? What did you learn in session 1?
The trauma or the non-trauma?
What did you learn in session 1? You have a weak muscle. What do? You take a history and you see, is there trauma? Or no trauma? This is from session 1. If there's no trauma, what do you think of pursuing? Right, that's when you check the 5 factors. The nerve supply, the Chapman-Bennett reflexes, the alarm points for the meridian system, which we haven't learned yet. We're going to learn that in session 5. And the cranial, sternal, sacral, breath in, breath out. And if it's trauma, then we want to check what? Is it compaction or shearing injury? Compaction, or more commonly, a shearing injury. Isn't that what we learned in session 1? Okay. Some of us did, maybe. Now, Bruce, have you had any trauma to your neck in the last month? Bruce, have you had any trauma to your neck in the last month? Bruce, have you had any trauma to your neck in the last month? Now, this is what you go through in the office. Okay, which is it, no or yes? Physical trauma to your neck in the last month. Were you letting anyone practice cervical manipulation on your neck that didn't know what they were doing? Is that physical trauma?
Yeah.
This is what you go through in the office. So number 1, usually George says that if you listen, the patient will tell you what's wrong with them. There are other times when you just forget what the patient tells you. Okay, so that's kind of that's just clinical experience. Okay, so now that we've determined that there has been trauma, you think we're going to go to the 5 factors?
No.
No. Where are we going to look? For this type of injury, okay, on the physical side, and when you have a shearing type of injury or a sprain strain, shearing type of injury is going to have what? A weak muscle. And what will that weak muscle respond to? Check origin and insertion first. What if it doesn't check out with that?
GTO.
Golgi tendon organs. What are the Golgi tendon organs? They are tension measurers, which are turned off switches through the 1B fibers. They are found at the musculotendinous junctions. And how would you turn those on? Go to the musculotendinous junctions and push towards the belly. And if it's not the Golgi tendon organ, am I boring you guys? Is it too slow? Okay. If it's not the Golgi tendon organ, could be the spindle cells, which are stretch receptors through the 1A and 2 fibers found throughout the muscle, but concentrated primarily in the belly of the muscle. And how would we turn those on? By going into the belly and pulling them apart. Okay. Now, what are you going to find besides a weak muscle? There's a trilogy to a sprain strain injury. The synergist will have the one type of trigger point known as a strain counterstrain. Strain counterstrain. And that is a trigger point that will reduce in pain on fold and hold And it's a strong muscle in the clear that weakens after a 3-second maximum contraction. That's the diagnostic part. Now, how would you fix it? Fold and hold. Okay, active on the doctor's part, passive on the patient's part. And if it's on the front of the body, it's flexion with the patient's breath held in. If it's on the back of the body, it's extension with the patient's breath held out. And the really important part is slowly you return the joint to its original position. Otherwise, you recreate the strain counter strain. And what's the main nutrient with strain counter strain? Folic acid. Okay. So if you just fixed it, you have tense all their muscles, and it brings back the trigger point, then administer folic acid. Okay. That's strain counter strain. Now let me give you 2 exceptions to that rule. The 2 exceptions are the piriformis and the neck extensors. Those are both done in flexion, even though they're on the back of the body. I wanted to wait and let that percolate in for a couple of months before I gave you the exceptions. Other than that, the flexion on the front, extension on the back is true. Okay? Now, where's the shortened muscle going to be? Where's that other type of trigger point? That's the what? That's the antagonist. And what will that demonstrate? Fascial flush. And that's a trigger point that will reduce unpalpable pain with stretch. That's a strong muscle in the clear that weakens after a gentle stretch. And how would you correct it? Right. Iron out the muscle along the muscle fibers towards the heart. What's the nutrition? B12. I see some of you have been studying. Okay. So let's see what's up with Bruce here now. He's got a weak upper trap and a weak SCM. So we're going to go here, bring your head all the way down, all the way left, push. It says it's not that. Let's try up here. Bring your head all the way down, all the way left, push. It says it's not there. Now what do I do? GTOs. So we're going to go here, head down and left, push. It says it's not that. Let's go here, push. It says it's not that. Well, now what do? Spindle cells. Let's use this hand. Turn your head so I can get to that. There we go. Bring your head down, left, push. It says it's not that, Well, maybe it wasn't due to trauma. We can go to the 5 factors. So we'll go to the lymphatic, first intercostal space, 3.5 inches from the sternum. Bring your head down to the left, push. It says it's not that. Maybe it's the neurovascular. That's the ramus here. Bring your head down to the left. It says it's not that. Maybe it's craniosternal-sacral. Take a big breath in, hold it in, bring your head down to the left, push. It says it's not that. Let all the air out, hold it out, push. Now it says it's not that, so it's not craniosacral. Maybe it's nerve supply. So we'll go to the vertebrae of the neck. Bring your head down and to the left. We'll do the uppers. We'll do the middle. We're just screening now. We're not doing individual ones. We'll do the lowers. No. We'll do the occiput. No. Okay, so it's not nerve. It's not a Chapman reflex or neurolymphatic. It's not a Bennett reflex or neurovascular. It's not cranial sternal sacral. We'll try the alarm point via the meridian system, which you don't know yet, but we'll try that. We'll go to the alarm point here. Bring the head down and to the left. Push. So it's not one of the 5 factors. It's not origin, insertion, GTO, or spindle cell. Well, Well, he said it would be one of those. Okay. Now, what's the hardest thing to do in practice? Think. When we treat a patient, any patient, do we want to treat the symptoms or the person who has the symptoms? What do you call this in AK? That's the triad of health. And at the foundation, we have structure, over here chemistry, and over here emotions. How would we check for we've checked that, it isn't that, maybe it's the emotions. How would we check to see if it's the emotions? Right, we just use our tool of therapy localization and go to the emotional neurovasculars. So Bruce, put your hand, Bruce doesn't have any, put the hand over the emotional neurovasculars, bring the head down and to the left, and push. No, it says it's not that, so we ruled that out. Maybe it's chemical. What are the nutrients for the SCM? Niacinamide B6, iodine. Iodine is used when? For sinusitis, for the stuffy, can't blow it out kind of sinus. What about the drip, drip, drip kind of sinus? Bile salts, and that's when we cycle up and down. And Bruce, do you have any sinus symptoms? No. No drippy or no stuffy. So it's probably not either of those. Might we check the niacin? Yeah, we could check that. And if it's a capsule, you need to open up the capsule. Yeah, niacinamide B6 is specific for the SCM. B6 niacinamide is specific for what muscle group? The scalenes. Now, Bruce, open your mouth, open your tongue out. Let me know when you can taste. Is that enough? Let me know when you can taste that. You taste it? What does it mean when he can taste it? His nervous system is aware of it. Bring your head all the way down, all the way left. Push. No, it says it's not that. Huh. Well, just rub the heck out of it, throw some hot packs on it, ultrasound it 30 times, and maybe we'll see what happens. Well, I need I'll tell you what, I'll just give you one of these bottles. Bruce, swallow that, but then leave some water in your mouth when you're done swallowing too. Got some in your mouth? Bring your head all the way down, all the way left, push. He's dehydrated. What did I tell you were the three, or at least two biggies up to this point? Water metabolism and blood sugar metabolism. He's dehydrated because his adrenals are shot. How much water are you drinking a day, Bruce? 5 or 6 cups. Are these small cups? Not too small. Okay. So he is drinking water. Okay. It's not like he's not drinking water. Are you drinking a lot of caffeine? 1 cup a day, that's not a lot of caffeine. Why did I ask that question? Caffeine is a diuretic. Okay. Are you taking lots of B6? No. Why did I ask that? B6 is a diuretic in high doses. Are you taking AC carbamide? Why did I ask that? AC carbamide is a natural diuretic. Are you eating lots of pies? No, Bruce. Be honest. We just had Thanksgiving not that long ago. Did you have lots of pies? Okay. So what does sugar do to the adrenals? It boosts them up. Now, bring your ear and shoulder together. Bring your ear and shoulder together. Are you trying? 1, 2, 3, go. Okay, nothing there. Hold that in your mouth. So who's eating too much sugar and not getting enough water? Hold that in your mouth. Now, can he heal if he's dehydrated?
No.
No, it's impossible, impossible. Bring that together. Bring that together. Is there a difference, Bruce? Bruce, I'm going to donate this to you. Let's reduce our pie intake and increase our water intake. And make sure you take the other good supplements. Okay? There's your problem right there. Was that good? Yeah. That's what you'll find in the office. That's a real life case right there. Do you mind if I tell him or about your symptoms? It's severe right suboccipital pain that comes and goes. Is that accurate or? Okay. And he flew to Vegas. Is it Wednesday night? And I treated him Wednesday night and found an anterior occiput on the right, which I set real well, and a category 1, and an anterior T5. And we did some emotional work as well. And I have him on Ligaplex 1 and 2, 12 a day of each. So at this point, he should be holding, but he's dehydrated, and that's what happens with dehydration. It'll goof up all your other work. Okay? So, Bruce, no pies. Notice I start with pies. No pies, cakes, cookie, candy, ice cream, soda pop, donuts, brownies, no bread, pasta, rice, and potatoes. Eat protein with veggies. I know you like cow. His favorite saying is, now is the time for cow. So eat protein with veggies and fruit. Just cut out the sugars and drink more water. And when you drink water, guys, with your meals, no, in between your meals. Don't drink a lot of water with your meals. Why? It dilutes your gastric juices. You won't break down your proteins properly. Okay? The best water to drink, in my opinion, I recently changed this in the last year, is distilled. I think that's the best water by far to drink. I personally have gotten parasites from bottled water, as some of my other patients have. So now I'm telling everyone to drink distilled. Distilled is what you use in the chemistry lab. It's what you use in your car battery and your iron. If you think you get enough minerals from mineral water, you're off in la-la land. You get your minerals from your foods primarily, and you may also need a mineral supplement. But I'm highly recommending to all my current patients that they drink distilled water. And it costs less or no more than any other bottled water, usually less. So, okay? All right. Any questions about the review? Yeah?
I'm question about the diet. Are you trying to convert my diet to talking about? It's hard to make a lot of changes at once. First of all, how could that be about the diet?
Say again?
How picky do you have to be about the diet?
How picky do you have to be about the diet? I tell patients, don't sweat the small stuff.
Yeah.
But in general, don't eat the junk food. That includes popcorn, chips, nuts and seeds, spicy foods. If it bites your tongue, it bites your intestines. Alcohol, if you drink, don't drink more than twice a week, and don't drink 2 days in a row. Chocolate or caffeine. Caffeine is okay, but only with breakfast. Those are good general rules. It's a common sense, pragmatic approach. Eat protein with veggies and fruit in between.
And of course, the bread in North American diet is not part of the main.
Right, that's why we're having a lot of the problems we're having. Who was the first society to have arterial and atherosclerosis? The Egyptians. They were the first cultivators. Yeah, just because it's popular doesn't make it true. During the 1400s, everyone agreed the earth was flat. So how could it be any other way? Because we all agreed at that time that that's the way it was. But it wasn't true, was it?
For example, you're having a sandwich today at Target.
Sandwich is good without the upper and lower part of it. So leave the middle of the sandwich. Yeah, see, that's what George does. If you see George at like when we have our annual ICAK meeting, and for the last few years we've been having student luncheons, how many have attended those student luncheons? A couple of you here, I know quite a few more that aren't here this time. And you watch George go through the buffet line, he'll have the lettuce and the tomato and the onion and the luncheon meat and the cheese, but he won't have the bread. He's 82 years old, been in practice over 60 years, married to a woman 40 years younger because his first wife passed on. And plays tennis, snow skis, researches, writes a manual every year, and practices full time. He's my hero. So I'm going to do what he does because it works, not because it's somebody's academic opinion. Now, you're welcome. Just do the best you can. I tell patients you're only human. Take it one meal at a time, one day at a time. And just do the best you can. The better you do it, the better you feel, the more you want to do it, because the more you want to feel better. It works. I can tell you that works. You can also do this little experiment. Get a group of 10 patients or whatever, 20, 30. Test them against a strong muscle, and then test them like with beef on the tongue. Okay, they usually won't weaken most of the time. Rinse it out, then test with potato on the tongue. Usually they won't weaken, but if you test them with both on the tongue, the beef and the potato, almost like 60 to 70% will weaken. Not all. What about anywhere from half to 3/4? Your body cannot digest the starch and the protein optimally at the same time. Try that sometime. Don't do it in school as a fun thing at lunch one day. See what you find. And use a digestive related muscle like a pec major sternal to the liver or a pec major clavicular for the stomach. I mean, don't use a lung related muscle like a deltoid or something. Or use a quadricep, a small intestine, or a lat for a pancreas. Try it and see what you come up with. See, I don't ask anyone to believe that's religion. I just say, see what happens. And I tell the patients the same thing. So you don't have to believe in anything the first visit, but give it a chance and see what happens. But do what I tell you to do, diet-wise, supplement-wise, exercise-wise. Okay? But I can tell you without reservation that diet works. You don't need a blood test and all that other stuff. Very simple, few simple rules. You don't need a book, you need a paragraph. Okay, now, are we okay? Or you need a wee break? Or so I'm just getting on a roll now. If you gotta go, go, but I'm gonna keep going. Yeah.
Challenge with converting children.
It's not a problem converting children, it's the parents. I can treat a child usually in 5 minutes or under. But I schedule them for 15 to 30. Why? To talk to the parents. It's not a kid problem, it's a parent problem. Okay? So, right. Okay. Let's get the projector on. Thanks, John. And, I forgot a part of this. On a sacral inspiration or expiration assist, is that a rebound or direct challenge? It's a rebound challenge. And is it a rebound or direct correction? It's a direct correction. That's on your test. Why is that? Because you're going with normal sacral motion on the correction. So, two good muscles, hamstrings and or piriformis, and if they're weak in the clear and they strengthen with the patient's breath in, what is that? It's a sacral inspiration assist. Okay? And you would push P to A and a little S to I on the apex of the sacrum on that side as the patient breathes in. And if they have a weak hamstrings and or piriformis that strengthens with the patient's breath held out, that's a sacral expiration assist. And explain what you're doing. Reach under the apex and lift A to P on the patient's breath out. Okay, so it's a direct correction, but it's a rebound challenge. That's on your test. Okay, muscles move bones, 650 muscles, 210 bones, and not only think of the somatic-gnathic system as a closed kinematic chain, but what? The entire body, like the cover of David Lee's flowchart manual, is a body made up of these gears. The entire body is a closed kinematic chain. Okay, let's review category 2, and then we're going to learn category 1, and then we'll workshop it. Okay? This is big bread and butter stuff. I know I said not to eat the bread, but eat the butter. Don't eat margarine, but eat the butter without the bread. But if you get good at this, you'll be known from coast to coast like what? Butter and toast. Okay? Thank you, friend. Okay, category 2. What will you see posturally? The EOP will be on the plumb line. Structures beneath will be off. They'll have a lateral sway. It's an osteoarticular problem on one side usually, so therefore you challenge and adjust. You therapy localize traditionally with the patient how? What position? Supine. Patient supine, and it's a one-hand therapy localization over one SI joint. Okay? Now, there are two basic types. There's a PI ilium and an AS ilium. Using Gonstead terminology, a PI ilium is UMS for upper fossa, medial knee tenderness, short leg. What are the three muscles? Sartorius, gracilis, rectus femoris. Okay. And what about the other one? That's how? LLL, lower fossa, lateral knee, long leg. And what are the muscles? Glute maximus and hamstrings. Okay, those are the two major types of category 2. What are the two subtypes? Right, internal or external rotation. And if we therapy localize the SI joint and it's positive, we have the patient take a breath in and hold it in. Let's say it negates RTL. Then what type is it? It's an EX. Why is that? Because that's how the ilium moves. As you breathe in, the PSS is approximate. So if a breath in negates DTL, it's an EX ilium. If a breath out negates DTL, it's an IN ilium. Okay? What are the two normal mechanical listings? PIEX and ASIN, that's normal mechanics. And what are the two traumatic listings? PIIN and ASEX. Okay, now, very good. Could you challenge for a category 2? Sure you can. Yeah, you bet. Sure you can. Okay, and is it a rebound challenge? Yeah, because it's part of the spine. Okay, now, how would you block for a category 2? With the patient in what position? Supine, the same position you would traditionally check for a category 2. And how long do you leave the blocks under the patient? How long? Until the arm fossa test becomes positive again. That's your titration point. The body will let you know that. Bruce, you drinking your water? Okay. Now, let's say I'm laying on a table and I have a PI ilium on the right. You place this block under the PSS, this block facing this block under the opposite ischial tube. Okay? Now, could I also have a left AS ilium? Yeah, it's blocked either way, left AS or right PI. And do you have to worry when you block the patient for a category 2 about the EX or IN component? No, because the body automatically takes care of it by respiration. while the patient's on the blocks. But you do have to worry about that if you're going to use a side posture adjustment. Then it becomes more of a critical factor. When would you choose, like, for example, to use blocks? Right, possibly if a patient is pregnant, emotional low back or ligament stretch syndrome over the SI joints, maybe a very osteoporotic patient or one that's in severe pain. Maybe they can't stand a side posture adjustment for whatever the reason. Even psychological factors. If a patient has been to a chiropractor 20 years ago and nothing else has helped them, so one of your patients dragged them in, and they're just deathly afraid of a high velocity adjustment, possibly you may want to break them in gently by using the blocks. Okay, and then once they come to trust you, remember FCB from session 1, faith, confidence, and belief in the doctor. Once they start to get to know and trust you, then maybe you could start using a high velocity when and where indicated. Okay, so there are definite times to use these blocks. Okay? Do I need to review the arm fossa pull down pass? That's from SLP. Okay. Rob, you're just handy there. You're sitting right up front, so come on up and now, will the iliac crest be level or unequal on postural analysis for category 2? Usually unequal. Okay? So let's check his leg length. I go to the medial malleoli. The left one is short. And more than that. Right on the insertion of the pes anserine, sartorius gracilis semitendinosus, SGT. I'm not over the medial meniscus. I'm right at the insertion of the muscles. Now, let's take a strong indicator muscle, bring this up, then push up, TL the left SI. Now, if he were a patient, I would put the hand there, but Rob is a doctor, he knows. We have a positive therapy localization push. Now what do? Take a breath in, hold it. So what is that? It's an EX, okay, for sure. Medial knee, short leg, thumb up towards your head, elbow straight. So I'm going to bisect the inguinal ligament in half and push in the upper half. We have a positive arm pull down test or arm fossa test. So how would I block it? Let's say I decided to use the blocks. Is it okay? Okay, let's say I decided to use the blocks. This one goes under the PSS. This one goes under the ischio tube facing that block. Elbow straight, thumb up, hold. The arm fossa test should be negative. The legs should be even, which they are. Much better on the reduction of pain over the SGT. Okay? Now I leave them on the blocks until that arm fossa test becomes positive again. Otherwise, you really don't know how long to block the patient. You're just taking a guess. But it's very important not to overblock a category 2. Okay, category 1, you can leave them lay there for a long time, 40 minutes if you wanted, it's not a problem. It indicates whether you have the blocks placed properly if it's strengthened. It indicates whether you have a PI or an AS, and it indicates when to remove the blocks. Hold this up here, elbow straight, thumb up towards your head. Hold real hard. Hold real hard. Now is that time to take them out yet? No, he's still cooking. I tell patients you're still percolating. Okay? Now, let me just ask you a question. If he had an inspiration, expiration, or spinobasilar inspiration or expiration assist cranial pulse, could I be doing that while he's on the block? Yes. Sure, you bet. You could be doing two things at once. Hold this up here, elbow straight, thumb up towards your head. There he goes. Is it time? Yeah, now it's time. You pull the blocks out. Now, I didn't test the sartorius or gracilis, but I was just demonstrating other parameters. Okay, legs are nice and even. Okay. Any questions on category 2? Do you remember how to adjust an ASEX if you went to do a side posture? Remember, that's a special type of Gonstead maneuver that you have to do. Do you remember how to do that? Some of you do.
I do.
I could. Okay. And, Keith, come on up. Did you snow ski yet, or snowboard? Okay. So Keith, we can pretty much demonstrate for the rest of the year now anything we want, because he's a maniacal snowboarder at his house, laying your back with your. You're not snowboarding, or you're snow skiing. He's also a maniacal snow skier. Now, he's got a big short leg on the left and a real long leg on the right. Okay. Not so bad. More here. And here. Bring this one up here. Push up. TL the right SI. Push up. Doesn't show. TL the left SI. Okay, we have a positive. Take a breath in. Hold it. What's he got on the left? An EX. He has a short leg. He has medial knee tenderness. Elbow straight, thumb up towards your head, pull hard. But he doesn't have an upper fossa. He has a lower fossa. Now, does that fit our pattern? UMS or LLL? It doesn't fit, does it? Oh, well, just throw a hot pack on them and electrify them and, ultrasound them and, whatever. Okay, when the patterns don't fit, remember posturally, blood, urine, x-ray, your physical exam, your palpation, your muscle testing, when things don't fit, what do you think of doing? Checking for something I taught you at session 1 called ocular lock. Okay. And I taught you my structure. Where's Dorothy? There's no paper on this flip chart. I taught you, maybe I can see here. Maybe we can, if I can flip it over. You have to be smarter than out of paper. Okay. Let's try that. Okay. Okay, if they weaken with eyes up to the left, what do you think of that? Occiput on the left. If they weaken with eyes up to the right, occiput on the right, does it tell you how it's subluxated? No, it just tells you that there is a lesion. If they weaken with eyes down to the right, that's sacrum on the right. If they weaken with eyes down to the left, that's sacrum on the left. If they weaken with eyes straight left, C2 on the left, straight right, C2 on the right, straight up, would be apex posterior sacrum or in bilateral inferior occiput. And if they weaken with eyes straight down, it's a base posterior sacrum. Okay, remember I taught you that at session 1? Ocular lock will clear out most switching, not 100%, but it clears out a lot of it. Elbow straight, hold real hard. Where do you start first? Eyes up to the right or up to the left. Always go to the occiput first. Eyes up to the right, eyes up to the left. Okay, what is that? You weaken eyes up to the left. Okay. Occiput on the left. Okay, eyes up to the left. That's good. Down to the right. Down to the left. Up to the right. So he's also got an occiput on the right. Now, I can challenge to find the vector, but I've done enough of these, I just feel it and do it. I mean, after a few thousand, you kind of get the hang of it. But, if you're not sure, you can always challenge. Eyes up to the right, down to the left, down to the right, up to the left, straight right, straight left, straight down, straight up. And that's pretty good, right? What's the hardest thing for the cerebellum to do? Turn the head one way and look back with the eyes the opposite way. Head to the right, eyes back left, head to the left, eyes back right. Okay, so we've got most of the switching out. Now let's recheck our parameters and see what happens. Any questions on ocular lock? If they weaken with the head one way and eyes back the other way, they're switched. You could go to K27, which we'll talk about in session 4. What I would do is therapy localize the upper cervicals or the pelvis or check the jaw. Any other questions on ocular lock? Okay. So, he's got a long leg still on the right. And here, TL the right SI joint. Push up. TL the left SI joint. Okay. Take a breath in. Okay. So what is that? He weakens by TLing the left with one hand. That's a category 2. He's got a short leg. Medial knee. Hold this up here. Elbow straight, thumb up. Don't let me pull. Doesn't show the upper fossa. Only shows the lower fossa. Does that fit? No. Short leg, medial knee, lower fossa is not UMF. So he's still switched. I happen to know what it is. But this is like a 5%. When ocular lock in general doesn't clear out all the switching, check this. I know you don't know what it is, but write it down. Check the hyoid. You can just set that by the side. We'll do that after a break. Thanks a lot. Just write it down. I know you don't know what it is, but just write it down. Hyoid. So the hyoid is like a little mandible under the mandible. We're going to learn about it in session 6. But he's switched upon switched here. When I hold his hyoid from left or from right to left, he weakens. And when I hold his hyoid, that's stretching the hyoid musculature on the right side. So I'm simply holding it from right to left. Don't worry about it, but I'm just going to fix it. One finger. Let's go here. Let's go here. Let's go here. So he's showing the anterior digastric. We're going to turn down the spindle cells to that. Hold hard here. Okay. So just write it down. When ocular lock, and this only happens in 5% or less of cases. When ocular lock doesn't clear out the switching pattern, check the hyoid. Just write it down. You'll learn about it at session 6. Now, let's go back to here. Still short leg on the left. TL the right SI joint. Bend here. Push up. Do your hand flat. Now, okay. Give me your hand. Do like this. I want you to TL right along here like that. Okay. Let me have this. Push up. Okay, that's fine. TL the left. Push up. Take a breath in. doesn't strengthen on a breath in. Take a breath out. Now it strengthens on a breath out. So what is that? That's an IN. He's still got a short leg on the left. Medial knee. Elbow straight. Now he shows upper fossa. Does that fit? Yeah, that's upper M short, UMS. Now it all fits, but you see how the breathing pattern changed. It went from an EX to an IN. So how would I adjust that? I could do it side posture. Go ahead and lay on your left side. And Keith, you're going to feel like you're going to fall, but you're not. I've got you. Okay? Let that leg go straight. So I'm going to take this involved side down. Let this just drop. I've got you. Let me roll you. Still a little bit short, but let's see. Better? TL the left SI. Push up. Now, on a 51%er, how can I check it? If you strengthen with the breath out, right, do the opposite. Take a big breath in and hold it. No, and it said it's still good. Okay, that was for a PIIN on the left. Is it possible to have a bilateral category 2? I know it's unusual, but is it possible? You bet. TL the right SI. Push up. Push up. Wasn't that negative when we started? But the body wanted what done first? It wanted him unswitched first and then the other SI done first. The body tells you what to do. Imagine that. Educated intelligence speaking to his innate intelligence. Imagine that. That's pretty cool, isn't it? Take a big breath in. What is that? So negated by a breath in. That's an E exilium, so we've got long leg. He said it's funny because now the lateral knee hurts, but before it didn't. Over. It's not the upper fossa, but it's the lower fossa. So does that fit? Yeah. L, L, L. Now it wants it done. But we had to do the PIIN on the other side first. I need a chair. Just give me, somebody give me a chair. I'm going to need a chair during the day anyway. I just need a chair. Yeah, thanks. Thank you. Okay. If you want to, now how do you correct this? If you block it, you don't have to worry about it, but if you do a side posture, he's got a right ASDX, the involved side goes down. This is why I don't wear a mic in the office. You have to reach around on the downside, grab the ASIS, you're going to pull back, up, and around. That's the only way to correct both components at one time. So, when we have a disassociation on an AS level, is it the upper or lower SI joint that dissociates? On an AS ilium, it's the lower SI joint. So I grab the ASIS, keep your foot behind your knee. I'm going to roll them towards me. There it is. Okay? It's a little hard because the table is a little high for me, but we got it. There's no kick, but you just stabilize with your knee up there. The thrust is pulling back up and around. That way you correct the AS and the EX component at the same time. Nice and even. Nothing. TL the right SI. Push up. Take a breath out. Good. Bring this up, elbow straight, thumb up towards your head, hold. Okay. So, you were messed up. Keep snow skiing, you would make a great demonstrator. He doesn't snow ski like normal people do. He gets speeding tickets on the mountain. And not by driving his car either. Okay? So he's hard on his body is the point. He's hard on it. How does that feel? I'm sure you do. Okay? Any questions other than I know you don't know the hyoid? But other than the hyoid, are there any questions over category 2? So you've seen blocking, you've seen side postures, you've seen the atypical ASEX, that's with a full move. Now let me give you a little more information. We're going to take a wee break. When we come back, we're going to discuss the SI joint probably in more great detail than you ever have before. On an AS ilium, the ilium is stuck in extension. The patient will swing the same leg through in gait. It's a lower SI joint dissociation, creating deep edema with pain radiating sometimes into the testicles or ovaries. The whole thing? Sure. On an AS ilium, it's a dissociation of the lower SI joint. The patient will swing the same leg through in gait to compensate. It's a deep edema with pain sometimes radiating into the testicles or ovaries. On a PI ilium, it's a dissociation of the upper SI joint, creating superficial edema, and the patient will swing the opposite leg through in gait to compensate. Okay, so let's do this. Let's take a 10-minute wee break. Okay, when we come back, we're going to discuss the biomechanics of the SI joint in detail, and we'll cover category 1. Okay. Okay, let's take our and continue on with our discussion of the sacroiliac joint. Were there any questions on category 2 before we start category 1? Because if you don't understand category 2, you're really not going to understand category 1. Going once, going twice, going thrice. There are 3 categories, by the way. We're going to learn category 1 today. Can we have the projector on, please? Thank you. Now, these next few slides are out of a book, The Physiology of the Joints by Kapanji. This is volume 3, which is the spine. The Physiology of the Joints by Kapanji, and the publisher is Churchill Livingstone. So that's where these slides are coming from. And according to Delmas has found that there are basically 3 different types of the root mechanism on the sacrum, depending upon whether the cephalid portion is more developed or whether the caudal portion is more developed. If the caudal portion is more developed, then the boot is markedly buckled on itself. It is more of a diarthrotic type of joint, closely resembling those of the synovial type. And there are increased curves, both primary and secondary, throughout the spine. Now, when you see this type of joint, you need to be sure to adjust through the full range of motion to get a proper correction. On the other hand, the extreme opposite of that is the cephalid portion more developed. This is found in children and primates, but in some adults as well. This is more resembling an amphiarthrotic type of joint, more towards the cartilaginous aspect. And when you adjust this, you have to be careful not to over-adjust. So you would modify your adjustment so as not to go as deep on the adjustment. And the one in the middle is sort of a combination of the two. So we have a dynamic type of spine, that would be a person like Dr. Faucret, and we have a static type of spine, more of my type of spine. So those are the two extremes types of spines. Now, Weasel has mapped this auricular surface of the sacrum in great detail and has found in general that there is a central depression which the tubercle of Bonaire from the ilium fits into. This is the boot mechanism. There are two other elevations here and here. Those bear the weight. They're the locking, but some pivoting occurs, but the main pivoting occurs in the central depression. Now, Faribault, who has also studied the SI joint tremendously, shows that on the iliac side, it's like a rail. Okay? It's a central depression, and then there's a matching furrow, sort of like a tram rail, on the sacral surface. However, if you cut it through different sections, if you cut it through A, B, and C, you slice it, you'll see A and B that the sacrum is concave. However, through the C section, you see how the sacrum is convex. This is why when you have a PI ilium, it normally goes EX for normal biomechanics, because it's following the course of the sacrum. So when the upper SI joint dissociates, when you have a flexion malposition, it has to go EX according to biomechanics. When you have an extension malposition, it has to go IM for normal mechanics. Can you see that? So it's based on the physiology of the joints. That's why we get those listings. Okay? So when you're adjusting, you have to be aware of these things and know what you're doing. Now, some of these ligaments, if somebody could tip the projector, the back end, it's like in pitch extension right now. If somebody could lift the back end up just a little bit, thanks, John. Now, if you look a little bit more, if you look up here, these are the iliolumbar ligaments, which we're going to discuss in a later session, session 7, I believe. Okay, let that go now. These are the anterior sacroiliac ligaments. These are the posterior sacroiliac ligaments. This is the sacrospinous ligament. This is the sacrotuberous ligament. Right where those two crisscross, that's your contact for a Logan basic. The piriformis comes through here, and the tendon of the obturator internus comes through here. Does anyone know what the second ligament is called? The S2 ligament? Playing joint trivia. It's the ligament of Zoglis. Zoglis was the first to talk about the notation, counter-notation of the sacrum in 1851. You won't be tested on that until 1851. Now, notation, counter-notation movement. Now, so we have basically ligaments that support the front and the back of the sacrum. These are very strong, and we also have ligaments that support rotation as well of the ilium and the sacrum. Now, when we therapy localize for a category 1, we do one hand over one SI joint, other palm up or palm down. What's wrong with this slide? The patient is prone. When you check for category 2, the patient should be supine. Over half the applicants miss that during the diplomate test. But don't forget to check it also weight bearing. And what else? Seated. So you may want to check it supine, seated, standing in a gait position, and also in a position of pain. For recurrent category 2 problems, support the organ gland what is the primary two organs for a PI ileum? Adrenals via the sartorius gracilis and the small intestine via the rectus femoris. Okay? And what are the two primary, what's the primary organ for an AS ileum? The gonads via the glute max and the colon via the hamstring. Muscles move bones. Very often with a category 2, you'll have a dropped navicular on the ipsy side. We'll talk about that next time in session 4. We're going to have an entire Sunday just on the feet. But very often with a category 2, you'll have a dropped navicular on that side. Remember, 25% of the bones of the body are in the feet. So if the shoes don't move, the dude don't groove. If they have a ligament stretch syndrome, what is this? Taking a strong muscle in the clear, stretching the ligaments, and then the muscle that crosses the joint weakens. That's a positive ligament stretch syndrome, which you can get over any joint in the body. Sometimes you'll see it globally, sometimes over just one joint, like a trick knee or something. You can also get that over the sacroiliac joint. Okay? And a high velocity adjustment is contraindicated if a patient demonstrates a ligament stretch syndrome over that joint, so you may want to block the patient. You correct this by correcting the adrenal glands via the 5 factors on a structural level, also by correcting the blood sugar on a biochemical level, and correcting also the emotions. Now, when we talk about adrenals, there's basically 2 types of firing. There's adrenergic, this is review. There's adrenergic, and that's alpha adrenergic is what? Inositol. And there's beta adrenergic, and that's what? Poladrenal. And then there are cholinergic. Cholinergic is choline. Okay? So if you take a sartorius that's strong in the clear and it weakens the whole adrenal, leave it on the tongue, see if choline negates it. If so, give choline. Your cholinergic type patients will be, for example, exercise-induced asthma. That's a good example of a cholinergic patient. Exercise-induced asthma. Now, inositol being alpha adrenergic, according to Dr. Schmidt, contraindication is hair growing out of the external auditory meatus. For beta adrenergic support, whole adrenal, one possible contraindication to whole adrenal is hypertension. So we have basically adrenergic and cholinergic fibers. All the parasympathetic pre- and postganglionic fibers are cholinergic. The sympathetic preganglionic fibers are cholinergic, but the postganglionic fibers are adrenergic. Okay, that's a review from session 2. Now, you cannot fix the adrenals without fixing the blood sugar. I'm telling you that. It's impossible. It's a temporary solution only. Solamente. Okay? So you need to fix that blood sugar. Now, are there any rules on Christmas Eve? No, not in my house. But it's not the one day, it's what? It's the rest of the year. Okay, so that's why they call it a holiday, because it's a holiday. Don't worry about it on a holiday, but not 5 days before and 5 days after. A wise guy. Now, a ligament stretch reaction, this slide should say a high velocity adjustment is contraindicated because no adjustment should ever be forceful. So a ligament stretch is stretching a ligament in any direction, producing a muscular weakness. A subluxation will produce it only when challenged in a certain vector. And a muscle stretch reaction is stretching a muscle and then it weakening the homonymous muscle. That's a muscle stretch reaction. So there's a difference between ligament stretch, subluxation, and muscle stretch. Is that clear for everyone? It should be. Is that clear? Now, we talked about the abdominals last time. I'm going to talk about them a little bit more this time. How many practiced the abdominals since last time? Okay. How many didn't practice? Okay. Thank you for being honest. Let's pick these up again. There are certain muscles that I tend to really emphasize. And could you put the light back? Just leave the fan on. Upper trap, SCM, piriformis, the abdominals, and the TMJ muscles. All the muscles are important, but there are certain key muscles. Just like the atlas is like one key vertebrae as an example. All the vertebrae are important, but there are certain key switches in the body. So upper trap, SCM, piriformis, and abdominals, as well as the TMJ muscles. Now, let's review what we learned last time. You're handy, Rob. You just happen to be sitting in the right place. Come on up and have a seat here. I'm going to do the muscle test. You guys yell out what I'm testing. Okay? Knees together. Make two fists. Hands up here. Sit up tall. Knees together. I'm going to push back, Rob. You push forward. What am I testing there?
Right rectus abdominis.
The right rectus abdominis as a group. Sit up straight. No, not your shoulders. Just there we go. Push forward. What am I testing here? The left rectus abdominals. Now, if we have time this week, and I'll teach you how to break them down into the pyramidalis, the first, second, third, and fourth medial and lateral divisions. Okay, if we have time. Okay, we'll do that tomorrow. I want to get through some more important material. Now, if I turn Rob this way, I'm going to be on the left front. So I'm testing what? The left anterior something. Remember, the external oblique fibers run like you're putting your hands in your pocket. So I'm testing the left anterior external oblique. Now, if I move my hand over to the other side, I'm on the right anterior side, and they're the opposite fibers. They're running this way, so that's the right anterior internal oblique. And if I walk around here, I'm on his left side again, and I'm lateral. So I'm a left lateral internal oblique. I push straight back through the shoulders. Left lateral internal oblique. And if I test by pulling this way, wait, is he cheating?
Yeah.
You bet. Now sit up straight, young man. Don't let me pull. What is that? That's the left transverse abdominalis. Sit up straight. And that's the right transverse abdominalis. That's the fibers that run this way. Okay? Now, lay on your back with your head up here. Feet together. If we bring the feet over here, we lift the feet up 2 inches. Stabilize at the hip. If I pull towards me, Rob, you hold. That's the left lateral division of the external oblique. That's the only one you didn't learn last time. The left lateral division of the external oblique. So both feet together, over, up 10 degrees, raise them up 2 inches, stabilize at the hip. I'm going to pull towards me. Hang on to the table. Okay, any questions on that? Okay. We'll do the individual sections of the rectus abdominis. I can do it now if you want, or do you want to wait? They're not that hard. Do it now? Okay. Have a seat here. Now, feet together, knees together, make 2 fists. Now, we're still going to be on the right side and the right knee. We're going to rotate 23 degrees towards that side. I'm going to bring him forward 15 degrees. That's the right pyramidalis. Now I'm going to bring him up straight. That's the first division of the rectus abdominis. I'm going to have him lordoze the lumbar curve. That's the second division. I'm going to go back about 30 degrees. That's the third division. And if I go back 45, that's the fourth division medial, and 45, that's the fourth division lateral. And that one's weak. Okay? So basically, we're still doing all one side. We're just rotating 23 degrees. 15 forward is pyramidalis. Straight up is first division. Lordosing is second. Back 30 is third. Back 45 is fourth. And 45 is fourth lateral division. That's really it. You now know all the divisions of the abdominals. Feet and knees together. So I'm going to turn them 23 degrees this way. I'm going to bring them forward 15. What am I testing? The left what? Left pyramidalis. I bring them back straight. What am I testing? What am I testing? Left first division. Sit up straight. What am I testing? Second division. Go back 30. Third division. Go back 45. Fourth division medial. Turn 45. Fourth division lateral. That's all there is. See, you're still doing all one side. Now we're breaking the individual components down. One more time. 2 fists. Sit up straight. Turn 23. I'm on this right side. So what am I testing? The right something. Bring them forward 15. That's the right. Pyramidalis. Go back straight. Say it. Say it. It helps. First division. Lordos. Second division. Go back 30. Third division. Go back 45. Fourth division medial and turn 45. Fourth division lateral. That's all there is to it. Okay? So we're now just breaking down into the individual components. We're going to workshop that a little later. Let's get the light on. We'll run through the slides. So when we're doing it as a group, we're just having them sit straight, right side to right side, right shoulder, right knee. We're testing the right side. But if we want to get more specific, internal oblique, we have to have them rotated. And external oblique, we have to have them rotated. Here's the anterior division here. Here's the lateral division here. Here's the internal oblique. Here's the anterior division here. Here's the lateral division here. Here's the transverse abdominalis. Okay, let's talk. How do you eat an elephant? One bite at a time. One bite at a time. Category 1. Posturally. The EOP and the gluteal crease are on the plumb line. Structures in between are off. EOP and the gluteal crease are on the plumb line. Structures in between are off. They have an A to P sway. The more they sway, A to P, the more acute it is. The less they sway, the more chronic it is. You'll have a bilateral first rib head tenderness. Take your handout out, where it says Category 1. Not your workbook, but your handout. Okay. Most of this is in your handout, some of it isn't. Okay. So Category 1, posturally, EOP is on the plumb line, gluteal crease is on the plumb line, structures in between are off. You'll have an A to P sway, bilateral first rib head tenderness. What about a Category 2? Unilateral first rib head tenderness on the same side as the lesion. But with a Category 1, we have a bilateral first rib head tenderness. The most tender side will be on the involved side. That's important. That's in your handout, but you may want to write it anyway. The most tender first rib head, both will be tender. One will be more tender. The most tender first rib will be on the involved side. That will be the side of the weak piriformis. And you thrust always on the non-involved side. So, for review, where's the most tender first rib head? On the involved side. Where's the weak piriformis? On the involved side. What side do you thrust on? On the non-involved side. And you never thrust into a block. You never thrust into a block. And did you know? You never thrust into a block. Now, here's what a Category 1 will demonstrate. You check for a Category 1 with the patient prone. How do you check for a Category 2? Supine. How do you check Category 1? Prone. And it's a two-hand TL, one hand over each SI joint. So I'm laying prone, I'm laying on a table now. This would be a Category 1. A positive one-hand TL over each SI joint. Now, if it doesn't show this way, it might show this way. If it doesn't show this way, it might show this way, or it might show this way, one hand up, one hand down. It's one hand over each SI joint. The involved side then will demonstrate a two-hand TL, two hands over one SI joint. So after you've identified a Category 1, then you place two hands over one SI joint. That's the involved side. That's the weak piriformis side. That's the most tender first rib head side. And where do you thrust? On the opposite side, on the non-involved side. You ever thrust into a block? No. Basically, you just learned Category 1. That's it. It's two-hand TL, one hand over each SI joint. Two hands over one SI joint will be the involved side. That's the weak piriformis side. That's the most tender first rib. And you thrust on the non-involved side, never into a block. Now, so in order to place the blocks, it's a little bit different than a Category 2. You're going to place the blocks with the patient in what position? Prone. Let's say I'm laying prone, and I have a right PI and a left AS. So it's like my pelvis is torqued this way. It's a torquing of the pelvis. That's what a Category 1 is. That's a form of dural torque. And if my right side is PI, I place a block under the greater trochanter this way and the opposite ASIS this way so that they're facing each other. This is how you block a Category. I'm laying prone now. There's a transparent table on my belly. So I'm laying face down right now. I either have an AS on the left or a PI on the right. Let's say my first rib head is most tender on my right side, and I have a weak piriformis on my right. Where are you guys going to thrust?
On the left.
On the left, you're going to thrust into my PSS or my ischio2. Into the ischio2. Why? You never thrust into a block. Okay, and how long do you thrust for? You keep thrusting until all the tenderness is out of the first rib head. That's your titration point. So you keep thrusting until all the tenderness is out of the first rib head. That's your titration point. There are two cranial faults associated with Category 1. I know you don't know them yet, but just write them down so it's in your notes. Temporal bulge. The old name is banana head. Temporal bulge. And the opposite of that will be a parietal descent. You'll very often have an atlas subluxation with a Category 1. temporal bulge, parietal descent, atlas. Keith, come on back up here. The reason I'm using him is because I know he's unswitched, for sure. And after very often you correct a category 2, then you'll have to correct a category 1. There are 3 categories from SOT. Category 3, category 2, category 1. Okay? Well, we learned category 2 last time. We're learning category 1 this time. Next session, 4, we'll learn category 3. Okay? Now, how do we check category 1? Prone. Now, very often, this is not in your notes, very often the patient will demonstrate a bilateral hamstring weakness. This is not written in your notes. Very often, a patient will demonstrate a bilateral hamstring weakness. So, bring your knee up or your foot up here, push back hard, hard, hard. Okay. Bring this one up here, push back hard. Okay, so we have a bilateral hamstring weakness. Okay, so can I use that muscle for therapy localization as a strong indicator? No, we have to use a different muscle. So I'm going to go to the piriformis, 23 out, bring the foot in, stabilize the opposite, pull in. That one I can use. Put one hand over each SI joint, palm up or down, doesn't matter. Bring that in, pull in hard. Do I have a category 1? Yeah, it's a positive 2-hand TL, one hand over each SI joint. Now what do I do? Right, both hands over one to determine the involved side. Pull in hard. Pull in hard. Where's the involved side? On the left, 2-hand TL. Where's the most tender rib head should be, the first rib head? On the left. Keith, is that more tender? Or is that? This one here. Okay, that's a positive jump sign. But wait a minute. Didn't I also say on the involved side we have a weak piriformis side? Yes. Only weight bearing. Get up on your hands and knees. We put the hips right over the knees. Observe. Observe. Pull in. Are you trying? Only usually shows weight bearing. They face down. Now, how do you know to place the blocks? You use a bilateral challenge with your thumbs. So we're going to challenge the opposite ischiotube and PSS this way and then this way. Pull in. Pull in. There it is. So his left ASIS and right PSIS, or I'm sorry, his left ischiotube and right PSIS challenge this way. You place the blocks opposite the challenge. So they go that way. The challenge this way, so I'm going to place the blocks that way. It was this way. So I'm going to place the blocks opposite the challenge, facing each other. And what should happen, the hamstrings should get strong. Let's bring this down. Push back. And they do. Okay? So if the challenge this way, this is PSS, ischiotube, how do you place the blocks? Opposite the challenge. Where do we thrust? On the non-involved side, into a block? No, never into a block. So his side was the left. I'm going to thrust on the right. It's under the greater trochanter. So I'm going to thrust on the right PSS. And you use a pumping action. Just like that. We go back and check for first rib head tenderness. He said, that's amazing. You don't always get that response. But we went from a 8, 9, or a 10 down to a 2 or 3. Not good enough. A 1 or a 2? Almost there. Great. That's a good place to stop. Did you see that? You thrust until when? The first rib head tenderness is down to a 0 or a 1. Also, what you'll find, both feet together, the hamstrings, when tested together, will be weak. When you place the blocks out, bring them up, push back, they'll be strong. And also, individually. Do that one again. Okay. And that's it. That's a category 1. Okay? Wait. Now, any questions on category 1? How do you therapy localize category 1? Patient is prone. One hand over each SI joint, palms down, or palms up. One palm down, one palm up. And then you determine the involved side. That's a 2-hand TL. That's the side of the weak piriformis, but may only show weight bearing. That's the side of the most tender first rib. You thrust on the opposite side, never into a block, and you challenge using your thumbs, opposite TSS and ischial-2. You place the blocks. If it challenged this way, you place the blocks that way. Okay, any questions on category 1? That's a positive challenge. Standard challenge mechanism. You just have to use 2 hands now to challenge instead of 1 hand. You're challenging opposite ischial-2 and TSS. Okay? Now, what else did I say you'd find? An atlas, a temporal bulge, and a parietal descent. Scoot to your right here. Take a strong indicator, bring the knee up. Now, how do you TL the atlas? With the patient's thumb, primary atlas technique. So we TL the atlas on the right. Nothing. We'll TL the atlas on the left. Right? Okay? Now, if it's lateral, he'll have weak what? Wrist flexors. Primary atlas technique. It's not lateral, it's just probably posterior. So lay on your back. And how could I determine that? Challenge it. Stand up here. Push. We can just challenge it. Okay. Well, it just clicked on the challenge, so I know that it's got to go that way. I mean, I just barely touch it and it will set it. Okay, come on up. TL the atlas on the left with your thumb. Okay. Good. Question on?
Even though it's not lateral, it's still challenge or TL positive also?
Does a challenge, okay, remember your rules. Does a therapy localization tell you how to correct something? No, but it will have a positive therapy localization if what? Something is wrong. So that locates it. It doesn't tell you whether it's lateral or rotated one way or the other. You can have just a rotated atlas. You can have just a lateral atlas. Very often you have both. In his case, you didn't. You just had a posterior rotated atlas. But it's the challenge mechanism that tells you what? How to correct it. Okay? So your locator, like the guide in your Magellan guide in your car, that's therapy localization, tell you where. But challenge tells you how. Okay? Any questions on category 1? Thumbs. Use your thumbs. Use your thumbs to challenge. Goodhart was very particular about that. Use your thumbs. Don't use your palm hand. Use your thumbs. Okay? Okay, so what I'd like, any questions on category 1? And you should also do what? Fix the piriformis by fixing the 5 factors: neurolymphatic, neurovascular, cranial, alarm point, nerve supply. Okay. Let's put the light on the projector. Now we'll go through the slides that we've gone through it, and then just kind of review, and then you'll workshop it. I'm not teaching you the temporal bulge or parietal descent yet, because I don't want to confuse you. I want to just teach you the lower half first. Okay? Kind of take it one bite at a time. Now the muscles here, these are all involved, but there are certain key muscles that are important I want you to star or highlight or underline. These are the piriformis, that's the most important one. Then the sacrospinalis and the quadratus lumborum. Piriformis, that's the most important one. That should be highlighted, underlined, and double starred. Then sacrospinalis and quadratus lumborum. So we have a 2-hand TL, 1 hand over each SI, patient is prone. We do 2 hand over 1 SI joint for the involved side. That's the most tender first rib and the weak piriformis, which may only show in a weight-bearing position. What's wrong with this picture? Right, the doctor's not using the thumbs. Use the thumbs and challenge the opposite PSS and ischio2. If it challenged this way, how would you place the blocks in this picture? Opposite. So one block would go here, the other block would go here. Opposite the challenge. Very good. So here's the block. How would that have challenged? Right, the left PSS and the right ischio2. So it would have challenged this way. So you place the box opposite the challenge. Let's say we had a positive 2-hand TL on the right SI joint. Where would you thrust? On the left, say it, and left PSS. Because we never thrust into a block. Could we somehow turn down that heat? That heat is blasting full blast. Just turn that off. Okay, so if we had a 2-hand TL to the right SI joint, we would thrust on the left PSS. Just ask them to turn off the heat. We don't need any heat. Okay. That's going to be my costume one year for Halloween. I'll close up banana head. Okay, we'll go over the 2 cranial faults after we workshop it. So, are there any questions over category 1? Okay, so here's what I'd like you to do during this workshop. Let's have patient is prone, doctor is testing, and do a bilateral, 1 hand over each SI. If not this way, check it that way. If not that way, check it that way or that way. Once you find it, then do a 2-hand TL to determine the involved side. Then you need to know how to place the block. That's the challenge with your thumbs. Challenge the opposite PSS and ischio2. Place the block opposite the challenge. Thrust on the non-involved side, never into a block, until the first rib head tenderness is down to a 0 or a 1. At that point, take the blocks out at the same time. Okay? And then the piriformis, check in the quadrupedal position. Remember, as humans, we are quadrupeds who have learned to become bipedal. We are still wired up as if we were quadrupedal. Okay, so let's do that. Let's take about 20 minutes to do a real good workshop on that. We're going to go over the 2 cranials and kind of wrap things up, and we'll go to lunch. Okay, were there any questions? How did that workshop go? Were there any questions from category 1? This is something you'll probably do to every patient, every visit. That's something you're going to do all day long. So this is not one of those things you'll use just on a full moon in June in a blue lagoon. This is something you're going to use all the time. I usually end every treatment with a category 1. Every treatment, every patient, every time, almost. Now, if it doesn't show prone, check it seated and check it standing. Just check it in different positions. Sometimes it will only show in a certain position. Okay? Any questions, category 1? Because everyone has dural torque. The question was, why do I think it's so common? Everybody has dural torque to some degree or another. Everybody. Whether it's due to structural, which is a short stride, weak psoas, whether it's due to chemical, like wheat, dairy, corn, or emotions. Everybody has dural torque to a certain degree. Everybody. If you're alive. So I mean, it's that ubiquitous throughout society. Okay. Any questions, category 1? Let's go over it. It's one hand over each SI, either palms down, palms up, one palm down, one palm up. Two-hand TL for the involved side. That's the weak piriformis in the quadrupedal position and most tender first rib head. We thrust on the non-involved side using our thumbs to tell us how to place the blocks opposite the challenge. We never thrust into a block. This is something you'll be doing like on every patient, every visit. So learn it well. Learn it right the first time. You're always going to have an atlas with a category 1, almost always. May not be lateral, could just be rotation. Okay, you'll have a temporal bulge and a parietal descent. Which is what I'm going to go over next. Usually, if you do a good job on the gait, the piriformis gait, the plus, the category 1 in the atlas, usually you'll clear the cranial. But I don't want to do those until we have category 1 down. It's that important. Category 2, category 1, muy importante. And they're just like really big stuff, like an octopus is a big thing, an atlas is a big thing. Category 2, category 1, big stuff. Okay. I'm AK, you're AK. Let's projector on. Bruce, you drinking your water? Okay. Now, come on back up here, Bruce. Let's see. How much water did you drink since you were up here? Okay. How many pies have you eaten? Okay, none. Okay, come up. Face that way. Look straight ahead and back up a little. Okay. Bring your ear and shoulder together, eyes open. Does that not hear? Isn't that different than it was? Did I adjust you? Did I do any muscle work? Did anyone else adjust you? That's just dehydration for him at this time. That's how important water metabolism is. It's a big change. How is the right octopus? It's what? It's what? Usually I go through that back and forth. Usually what I've learned is, first of all, people don't listen. They don't see. And they don't feel. Now, physicists tell us we're aware through our 5 senses, 5% of reality. Psychologists tell us at the most we're aware of 1%, which means we're at the most 1% of 5%, which means we're not at all. Now, bring your head down, into the left, push. That's different. Why do you think I stress certain things? Do you think there may be a method to my madness? That is different than all he did was drink some water. Now, Bruce, look straight ahead. Turn that light off, John, please. Look straight ahead at the horizon. Step forward on your right foot. Bring your ear and shoulder together. Hold hard. Bingo. Bring your head down into the right. Hold hard. Bingo. Step back even. Rudy, quit eating sugar. Look straight ahead. Step forward on the left foot. Bingo. Bingo. Isn't that what it's supposed to do?
Mm-hmm.
Then forward 30 degrees. Bingo. Back 15. Bingo. Should be like that doggy in the back window. The head flop. Yeah, in those positions. That's the way it should have been. Just like that. Have a seat. Face that way. Palms up. Bring your ear and shoulder together. Hold hard. Then forward 30 degrees. Bingo. Bingo. No publication there now. You're dehydrated. Dan is watching. Don't forget. Don't miss the obvious. I'm deciding. Okay, I'll tell you. I have this patient, as I have several that come in from out of town, and I treat also his son. His son gets stomach pain after they feed him ice cream. And I say, don't feed him ice cream. Then they do thousands of dollars of expensive exotic tests, find nothing. Then they call me, but he still gets stomach pain after ice cream. And I say, but don't feed him ice cream. Yeah, but other kids can eat ice cream. Yeah, but not your son. And then we go through this about a couple of times a week. Then he'll bring him in, I'll fix him, and he'll be okay for a few days until they pull the sugar again. And then I'll get a call. You get stomach pain after eating ice cream. Yeah, don't feed him ice cream. Yeah, it's about at that level. And this guy is a very intelligent man, believe it or not. But don't miss the obvious. In the wintertime, somebody comes to you with a multitude of symptoms. They are pure white. I mean, they haven't seen sun in 30 years. And you check their diet according to their diet history, looks pretty good. What does it tell you? They need vitamin D. Quadriceps are related to small intestine or vitamin D muscles. Don't miss the obvious. Everybody wants to look for the polka dot zebra in North America so they can be the big hero. When you hear the counting of hooves in North America, don't go looking for polka dot zebras. Look for the obvious. Look for cattle or horses. Then, if you don't find it, then look for the unusual. But we don't live our lives by the exception. We live our lives by generality. Don't miss the obvious. Goodhart says if you listen, except in Bruce's case, if you listen, the patient will tell you what's wrong with them. Most of the time. If you listen with ears that truly hear and see with eyes that truly see and feel with fingers that truly feel. And the hardest thing to do in practice is think. Patient got new shoes for birthday and they start walking like this. What is that? Tight shoes. Compress the transverse metatarsal arch, shuts off the spinal extensors, via the positive support mechanism. Don't miss the obvious. If somebody tells you, I was letting my girlfriend learn occiput adjusting on me for the last week, and then they call you and they say they have such severe suboccipital pain that somebody told them they had a tumor, go to the obvious. Well, maybe don't let your girlfriend learn on you. Adjust it, leave it alone, but do what? Drink water, don't eat sugar, and eat healthy, and it'll be fine. Don't go looking for that polka dot zebra. Go for the obvious first. I'm just trying to do my job, guys, really. That's what I'm doing up here. Yeah, I'm supposed to be a teacher. I'm trying to be one. Okay, let's get the light on. Now, there are two cranial faults. These are the first two you're going to learn of the rotational group. Remember, there's flexion extension, rotation, and sutural faults in applied kinesiology. These are two of the rotational faults we're going to learn. Very easy. Temporal bulge, the old name is banana head. So if you're ever taking the diplomate test, remember that banana head and temporal bulge are synonymous. Okay. Temporal bulge. Now it's called that because one side will be convex. That's the temporal bulge side. This is in your handouts. This is not in your workbook. So if you look in your handouts, it should be in your handouts. Yeah, it's right here in your handouts. Basically, everything I'm going to tell you is in your handouts pretty much. Okay? So this is all in your handouts. The indicator is category 1, bilateral PMC when tested together. Bilateral PMC when tested together. That will be strengthened by the patient's half breath held in. So it's not a full breath in or a forced breath in, it's a half breath in. Then you're going to challenge the occiput and frontal bone together or in clockwise or counterclockwise direction. I'll show you. So we have a bilateral PMC when tested together. That's strengthened by what? Patient's half breath in. And here's how we challenge, not on the temporal bone. That's the most common mistake made. We're challenging on the occiput and the frontal bone. So we're challenging together, either clockwise or counterclockwise, to get the vector. And it's corrected by a patient's half breath in as you compress in the challenge direction. It's all in your handout. This is associated with hypochlorhydria. Rob, did you get your... I'm selling my FXR. It's an 88, brand new, 10 to 1 business, SNS color, Python type, EB 27 PM. All chrome polished out. Andrew's Deca here. Okay. Sorry. Health Anna. Hypochlorhydria. Now, if you get burning after a meal, burning of the stomach after a meal, what is that? That's hypochlorhydria. If you get burning on an empty stomach, what is that? That's hyperchlorhydria. So burning on an empty stomach is too much acid. Burning after a meal is not enough acid. You're going to find in your practice, or at least I have with my patient population, that the hypochlorhydria is much more common than the hyperchlorhydria. Is it a simple question, Ryan, or is it one of the Ryan questions?
It's simple, not Ryan question.
Okay, great, then ask away.
Patient has burning when they take Dican, given this correct.
Okay, a patient has burning when given a supplement, probably not the correct supplement, or they're not taking it at the correct time. Now, you can correct this temporal bulge and have a patient suck an antacid tablet and it brings it back like that. Anybody have any of those here that's willing to admit that they have them? Anybody have any? Why are Tums not a good source of calcium? Right, because you need an acid medium in order to absorb calcium. Calcium precipitates out of solution in an alkaline environment, number one. Okay. At least they've taken the aluminum out now. You know, you don't find too many aluminum deficiencies. Okay. Sometimes, if you have a bilateral lower trap weakness, it will cover up a bilateral PMC weakness. That's probably not in your notes. A bilateral lower trap weakness will cover up a bilateral PMC weakness. And that's due to a thoracolumbar fixation, which we're going to learn today. Okay, now the other one is on the other, here we are correcting it. So we're either going to be either counterclockwise, not on the temporal bone, or on the occiput and frontal, or we might have to go the other way, or even just straight together. What's the third leading cause of death in the U.S. at this time? Iatrogenic causes. Take a good history and make sure they bring in everything they're taking on their first visit. Prescription and non-prescription. Make sure to cover all three sides. In 8K, what I tend to see is people tend to do a good job here and a good job here in general, and then they kind of forget that part of it. So the whole thing just collapses. Don't do that. Now, parietal descent, you're going to find opposite the temporal bulge. So, for example, if you had a parietal descent on the right, if you had a temporal bulge on the right, you'll have a parietal descent on the left. This is in your handouts. This is from Dr. Lee's flowchart manual. The indicator is scalene weakness. The anterior scalenes will be weak. They'll be strengthened by the patient's half breath out. Half breath out. It's scalene weakness on the side of the parietal descent that will be strengthened by a patient's half breath out. And you simply lift the parietal bone on patient expiration. I'll show you, we're going to demonstrate in 2 seconds, but you just lift it on expiration. Now, think. What muscle might be hypertonic that would cause that? We haven't covered it yet, but I know you know it from school. What muscle would cause that fault, being hypertonic? Temporalis. If the temporalis is hypertonic, it's going to pull the parietal bone down. Remember, muscles move bones. According to Penfeld and Rasmussen, 35 to 40% of all the motor and sensory nerves of the body are related to the TMJ, making it the most important joint in the body, according to Penfeld and Rasmussen. Rob. Okay, can we get the light off? And we did the category 1 and 2? Okay, we did category 1 on heat. Okay. But we already took his Alice. Now, hold hard. Okay, what is that? What does that indicate? It's a bilateral PMC. Now, let all the air out. Take a half breath in. Strengthen by a half breath in. So that confirms we have a Temporal bulge, does it tell me what side it's on? No. So I can just palpate that. Now to me, it palpates more bulging on the left than on the right. That's why they used to call it banana head, because one side would be concave and one side would be convex. It would palpate that way. So I'm simply going to go to the side that palpated. I'm staying off of the temporal, and I'm going to push the mastoid and occiput together. Let me get a strong indicator to make sure. Okay. So I'm going to challenge these two together. And just pushing them together is the proper vector. So I just push straight together. If that didn't get it, I would try it clockwise or counterclockwise. But just straight together for him was fine. Okay? Let that go. It's okay to fix. Breathe in deep. And now I'm not on the mastoid, I'm on the occiput and the frontal. And it's corrected on what? The inspiration. You're just moving. Okay, we do it 4 to 5 times. Okay, now, he's strong in the clear. How can I check him for a 51%? Right, take a full breath in and let half of it out. No, it says that's fine. Okay, any questions on that? That's as complicated as it is. Any questions on that? What's opposite the temporal bulge? Parietal descent. So hands up, Detroit position. Lift your head up, chin to your chest. Turn it a little bit. Push up. So we have weak scalenes on that side that are going to be strengthened by opposite the temporal bulge. Half breath out. Lift your head up. Take a big breath in. Hold it. Let half of it out. Let a little more out. There it is. Okay. So weak scalene strengthened by a half breath out. How do I fix it? I lift off the parietal bone, being careful not to jam the sagittal suture on expiration. So I'm just going to take a contact on the parietal bone, breathe in and out. I'm going to lift on expiration, but I don't want to jam the sagittal suture. Okay. Hands up. Detroit, lift your head up, chin to your chest. Turn a little bit. Now, half breath out strengthened, so how can I check him for 51%? Half breath in, let all the air out. Take a half breath in. Okay, and that's fine. Okay, and that's it. So lifting up the parietal on expiration for parietal descent, pushing occiput and frontal bone together on inspiration for temporal bulge.
What are you doing special that would show, make it see that you don't have suture to the pattern?
You can either take a thumb on either side of the suture, and as you lift the parietal bone, separate. Okay. Yeah, you just don't want to pull it up and around to jam it together. Good question. Now, somebody asked the obvious.
How long does that last?
How long does that last? Chew. Grind. Swallow. We have this 30-visit program and stuff like this. Lift your head up, turn a little bit. If you do a good job on the gait, the plus, the feet, the TMJ, the body usually will fix all of that for you. Now, when you have TMJ, you're going to have cranials. When you have TMJ, you have atlas. When you have atlas, you have TMJ. Hippocrates said, look to the spine first. He didn't say only. Look to the spine first in health and disease. Now, this. What am I checking?
Parietal technique.
Maybe you're not ready. Ready? 1, 2, 3, go. Where should it be lateral?
On the left.
On the left, and it palpates that way. You must be Italian, Ron. Okay. I know them a little bit, so I can joke with them. Okay. Hello. And it's an ASLA, so I'm going to take rotation. Now. Okay. Both hands up here. Hands up here. Lift your head up. Okay. Look to the spine, not only, but look to the spine first. You do a good job on the spine, you're going to get most of it. I didn't say all of it. You're going to get most of it. So start there. Listen to me. I've done it the hard way. Learn from my mistakes. Okay? Look to the spine first. I'm going to show you the easy way to practice. And the best result. Okay? Any questions on temporal bulb striatal descent? You still need to know how to do it though. You still need to know the indicators because sometimes you still have to unlock the cranium once or twice to get it going. Okay? But usually it's the flexion extension pulse. Inspiration, expiration assist, or spinobasilar inspiration or expiration assist. The rotationals are usually compensatory to the flexion extension. Not always, but usually. Okay, let's get the light on. We're going to finish this up and then we're going to go eat. But no starches, because this is not Christmas Eve. Actually, no, I guess that's a good place to, then we get into the trapezius group. Why don't we start this after lunch? Wait. We got 12 minutes. Wait. Okay, let's get the light off. Let me teach you really useful in 12 minutes. Did I teach you hidden cervical disc this year? Would you like to learn it? Because it's a biggie. I can teach that to you in about 15. Okay? Then we'll go eat. All right. This is a big, as big as category 2, or 1, or atlas, or octopus. This is huge for ocular lock, or lateral octopus. Okay. Hidden cervical disc. What you'll have are weak wrist extensors, not flexors, weak wrist extensors. And or triceps on the side of lesion. I don't give it all off at once, usually. You never know when I'm going to throw something out. Weak wrist extensors and or triceps on the side of lesion. Palpable pain in the triceps surae on the side of lesion. And it's an anterior cervical on that side. You thrust lateral to medial, A to P, and S to I. Exact opposite of Gonstead, except for the lateral to medial part. It's lateral to medial, A to P, S to I. I'll show you. This is huge. You can get sciatica from a disc in the neck. It's one cause, not a common one, but it's one cause of sciatica. Common cause of sciatica is what we're going to learn tomorrow, the real secret valve. That's 9 out of 10. The nutrition is SOD, superoxide dismutase, as found in whole desiccated spleen. superoxide dismutase, as found in all desiccated swing. Now, let me ask you this. If you have weak wrist extensors, where's the trigger point going to be? Medial epicondyle, so-called golfer's elbow. Rudy, come on up. You're chewing on something? Good. Come on up. Now, Rudy's in chiropractic school, which means he's donated his body to science. Now, like we all have, right? Now, make a fist, elbow straight. He's not weak, he's pretty strong, fit guy. Well, maybe he's not right. Elbow straight. Don't hold your breath, but elbow straight. 1, 2, 3, go. Oh, that's just weak. And elbow straight. Bring it down. Hold. Might also have weak tricep, possibly. Push out. Push, push. Oh, maybe not right. Push out. Come on, look up. You see the lean whole body? Push down. Push down. Okay, so you may have weak wrist extensors and/or triceps and palpable pain in the calf. Now, the interesting thing about how this therapy localizes is it won't therapy localize in the back, it'll localize in the front. I'll show you. Now, bring that knee up. Look straight ahead. Are you on any medication at this time? So give me one finger. Now, I'm not going to do the atlas, so I don't need the thumb. So I'm going to go C2. Push. C3. Push. C4. Push. C5. Push. Okay, nothing there, right? Go C2. C3. C3. See, it won't tail in the back, it'll only tail in the front. Now, you have two options here. You can pull it, a supine move with an SP pull, or you can do a seated move opposite the God set. And that's what I'm going to do. That's okay. That's what I'm going to do. Okay. So, it's lateral to medial, but it's in, should we do it up on, it's just that it's on rollers and the stage is split. So I didn't want to, I don't have a stationary chair here. But it's lateral to medial, but it's A to P and S to I to follow the joints of Lushka. Now, so we're going to go 1, 2, 3, bingo. Right there, bingo. So, it's okay. Let me fix it. And that was a double set. You could hear it, oh, across. Okay? Come on up. Make a fist, elbow straight. Push down. Well, he's strong, he's strong. Okay, but we didn't fix this side. Are you sure? Push down. Elbow straight. Okay, so have a seat. This way. in this one. Okay, so we get one finger. We'll go to C2 in the back. Now he knows where they are, so I just tell him. C3, C4, C5, C6. Okay, now try C2 in the front. C3, C4, bingo, bingo. See, it always shows in the front. I'm going to show the other way, but this is like opposite the Gonstead, is okay. So it's lateral to medial, but it's A to P, S to I, instead of P to A, I to S. So we go 1, 2, 3, bingo, right here. Okay. Let me feel it. Let me do it. Okay, come on up. You needed that, that's why I did that. Keep a fist, elbow straight. Push down. Okay. All right. That's how you do it. What's the nutrition? SOD, superoxide dismutase, found in whole desiccated squame. Okay? That's the push method. So it's just like we learned in Gonstead, but it's not posterior, it's anterior. So you still go lateral to medial, but instead of P to A and I to S, you go A to P and S to I. You're going to butcher a few people the first time you do that. But, you know, don't you also do that on the atlas when you first learn the atlas? You don't even know, like, where the atlas is, right? Okay, so you're just going to have to practice it. And then once you get it once, you feel it, you got it. Once you get it once, then you'll know what it feels like. The other way is to do an ST pull. And why don't you come on up? Take off your watch. Okay. Make a fist, elbow straight, push back, but don't bend the elbow. Now bend the elbow just a little. See how I'll miss it? Now straighten the elbow. See the difference? Push down. Not so bad there, but a little bit. Now, have a seat. Why do I like to check these seated? How many pounds of pressure do you put on your disc when you sit? 300. How many when you stand? About 100. How many when you lay down? 25. Scoot towards me this way. Bring this knee up. Sit up tall. Okay, give me one finger. Other hand. Go C2. C3. C4. C5. C6. Now go in the front. C2. C3. C4, C5, or C5, it's at C5, I realize, but don't do that. And he's pushing down on the table, that's why we always have the hand that way. Now push down on the table. See how he can negate it by pushing down on the table? Why? Takes the pressure off his mind. That's why I always do palms up seated. So the supine way is okay. The supine way, lean your back with your head up here. This is a pull move. Just like if you were doing a side posture lumbar, you can push a lumbar or you can pull a lumbar, depending upon what you want to do. Okay? So we're going to go, okay. We go 1, 2, 3, 4, and go 5. I'm going to hook the SP and I'm going to pull it around.
Here's the anterior side here. I'm going to pull it around. It's a pull move. You feel it. And you always do a pull move in flexion. There it is. Come on up. One finger, go to C5. Same spot. Bring this up. Now, to see if we really got it, push down on top of your head hard. And heel. No, it says we really got it. Come on up. Make a fist. Don't bend the elbow. Push down. Okay. Okay, that's hidden cervical disc. Biggie, biggie, biggie. Yeah. No, I did it supine. No, if I'm going to do a push, I'll do it seated. It has to be biomechanically correct. You can do it supine, but you'll get a better seat. How was it, Rudy? Well, I know you needed that. I was watching you driving me crazy. Okay. Any questions on, okay, now where is that in our protocol? So let's say you got a patient coming in, and you're thinking from a structural viewpoint now, and now you guys are starting to know enough of the alphabet where we can start to have a dialogue. Probably the first thing you want to check is ocular lock. Why? Why would you start with ocular lock? Right, to get the static out of the system, to get clear, accurate data from the patient's body. This is not carved in stone, but this is just one method, okay? But you could try it. And put under here a little side note, hyoid, like you saw with Dr. Christian today. I know you don't know hyoid yet, that's okay, just put it in there. So after ocular lock, a good thing you may want to check, you might want to check lateral occiput. Do you remember that? Tongue straight out, doesn't weaken out and to the right. If they weaken, that's an occiput on the right. And you may want to also put in here primary atlas technique. Check lateral occiput atlas. Then, check gait. The upper trap should be inhibited on what side? Same forward leg side. Which SEM? Opposite. Then you may want to check piriformis gait. Yeah. Piriformis gait. Then you might want to check plus. Make sure they're bending properly. Here you might want to put hidden cervical disc. Okay, I mean that's not carved in stone or anything, but that's not a bad structural protocol. Generally, start with structure first, in general. So get them unswitched, check the upper cervicals. The cervical spine has 7 times the mechanoreceptor than anywhere else in the body. So BJ was right. Gait, piriformis gait. If the shoes don't move, the dude don't groove. Check to make sure they're bending properly. That's the plus. Check that hidden cervical disc. That's not a bad, for what you know, that's not a bad protocol right there.
At what point are you able to tell when the patient I communicate on and there's point
good question. At what point does the patient's body have enough? From an AK perspective, I'll be able to better answer your questions after session 6. But seeing as how we're in the middle of session 3, I'll try to answer it as good as I can. There are certain basic things that should be functioning properly, in my opinion. All of that, you could add to that. I wasn't going to add anything, but since you asked, feet, you want to do the shock absorber on the feet. You're going to learn that at session 4. You're going to want to check pitch roll yaw tilt. You're going to want to check ileocecal valve, retrograde, T and J. That's why I wasn't going to add anything yet. Okay, so there are certain basic things that, I try to teach AK as if you were bowling. And the most efficient way to bowl is to hit the kingpin at the proper angle and get a strike every time. That's what the experts, the pros can do. And that's the way a professional AK guy can do it, is that he can get many things fixed by doing just a couple of things. But he knows where the weak links are and hit those, like hit the bullseye or that kingpin, or we load the bases up and then we put Casey Jones at that and hit a grand slam out of the park. That's an efficient way to bowl, play darts, or to play baseball. Okay? So I'm trying to show you an efficient way by doing the few key things. You're going to get a major cascade of effects. Okay? All right. Anybody hungry? Okay. Now, here's how you should eat. You should have protein. Beef, fish, chicken, turkey, pork, lamb, and eggs with vegetables. Any kind you want except for potatoes. No bread, pasta, rice, or potatoes. Pies, cakes, cookie candy, ice cream, soda pop, donuts, brownies. Eat fruit in between your meals, but not fruit juice. Have a good lunch. We'll start at 2:15. I give you a little extra time. Call your friends in from outside. Had a nice steak for lunch here. The salad and asparagus. I feel great. And if you didn't have any starch, I'm sure you're going to feel the same. Bread, pasta, rice, or potatoes, pies, cakes, cookie candy, ice cream, soda pop, donuts, brownies. Is this somebody's Starbucks here? Any questions from the morning on category 1? Temporal bulge, parietal descent. Now, who did I correct temporal bulge on? Rob, was that you? Come on back up. Land your back with your head up here. Both hands up here, elbows straight. Bite, chew, grind, swallow. Take a full breath in, let half of it out. Okay. So that, at least it lasted that long, right? Now, I have here this magic pill. It's only magic as long as you don't know what it is. Suck on this for a second or two. Okay. Now get rid of it. That wasn't that long, right? Do you have water? I got so much water up here, just rinse it out. So we're not testing the actual substance, are we? So what was it that I had them stuck on for a few seconds? It was an antacid tablet. I won't mention a brand name. It was an antacid tablet. I mean, that's how quickly that brought back that temporal bulge. Are you kidding? Or He says, my stomach feels bad now too. So we fix it. Well, his atlas is out too. Sure is. Wasn't it lateral on the inside? So that's something that makes a good demonstration for patients as well. Remember, the term doctor means teacher. You need to be one. Not towards me, Rob. You're kind of. And it's set just as deep as before. Take a big breath in, but half it out. Okay, so these are up here if you want to play with those. But it's really, that's really a big part of the problem. If you think about the amount of medications that the U.S. population consumes every year, now realize that sometimes medications can be life-saving at the appropriate time, the appropriate medication for the right person. But in general, that's not the way it's practiced. I mean, so it can create big problems. That's just one simple demonstration. Now, what I'd like to do is go over the muscle testing and maybe then go through the slides. So let me do it that way. Let's go through the muscle testing on a practical level. Then it'll sink in your mind a little better to go through the slides. So we have the middle trapezius, the upper trapezius, the lower trapezius, the serratus anterior, the deltoids as a group, the neck extensors, the popliteus, the teres major, and the adductors, ADD. So what I'm going to do is go through all those muscles. A lot of those muscles you need to know for learning fixations. So let me just take someone up here. Rob, you're handy again, so come on up here. Now, you already know the upper trap. So let's go right to the middle and lower trap. Go ahead and lie face down here. The lower trapezius, you turn the head toward the side you're testing. You bring the arm up, elbow straight, thumb up towards the head. And the test is to stabilize the opposite shoulder. And you test, and they should end up with the arm. If you're testing from here, it should end up in front of the nose here. The test is not pushing straight down, but the test is in front of the nose here. The middle trap heads to the same side, arm is perpendicular, and you push down and in. So he has a middle and lower trap on that side. Let's try this side, Rob. Bring the arm up, elbow straight, bring it up here, push. Now that one's okay. Let's try the middle one. Not so good on that middle trap there. So that's upper and middle trap. Okay? Upper trap you already know. Let's test as long as he's in this position, the neck extensors, hands up like Detroit. Don't forget, whenever you test the neck muscles, either supine or prone, the hands must be up. To test them as a group, you're going to push down and into the table. If that weakens, that's usually a lumbar fix. Turn your head to the right. Now, he is weak on the one side. If it's weak just on one side, tested individually, that's an iliac fix. If he is weak on both sides, that's a sacral fix. Okay? So neck extensors as a group, lumbar. If it were just one side, iliac, but if it's individual both sides, that's a sacral fix. Okay. Now, work through these here. we have the neck extensors. Okay, also we have teres major. Teres major, you put a fist to do one at a time. Put a fist behind the back, bring the elbow in. You're going to push in a geometric circle, stabilize the other side. To test them as a group, here's how not to test it. But you simply cross the arms and test. See, he shows it this way, but he doesn't show it this way. That's the way you'll see most people test it. That's a mistake. Go ahead and lay on your side, facing them. We're going to test the adductors, ADD as a group. Feet together. Stabilize here. We're going to raise the top leg, bring the bottom leg up to it. Push up. Push up. Okay, that's weak. We're testing the down side. Most of the time you'll see the adductors tested supine, and that's a poor secondary test. The best test for the adductors, ADD, like the gluteus medius, is the side posture test. Okay, lay on your back. Popliteus, we bring the knee up. Foot is up and in. Knee should be in the center. We're looking at the tibial tubercle. We're going to stabilize the lateral ankle and push out. And it's whether this gives, not whether the foot gives. That's popliteus. Okay. Come on up. We'll have you sit up now. And come down towards me here. The middle deltoid. Stabilize the opposite shoulder. And we're going to push not straight down, but we're going to push down and in. That's a weak one. That's the middle delt. Down and in. Anterior delt. Bring the arm up, stabilize the back of the shoulder, push in line, that's anterior delt. Posterior delt, bring the arm down, push in line, that's a weak one. That's a weak one, that's posterior delt. Serratus anterior, elbow straight, thumb up. This is the upper serratus anterior. This is the middle serratus anterior. This is the lower serratus anterior. That one's okay. This one's weak. That one's weak. So it's upper, there you go, middle, lower fibers. The upper, middle, and lower fibers. Serratus anterior. Nice. Is that all? I think we got it. Yeah. Okay. We're going to go through all the slides, but I wanted to do the practical first, then go through the slides. Okay, so you like hit it twice. So why don't we do that? Rob, you stay up here with me. So let's take your things off the tables, and we need doctor and patient. Hector Elsmeyer's tomorrow with record rate. Or Keith, why don't you come up? Let Rob work on Okay, let's have patients seated. Let's do this military style. Okay, books, papers, water, off the table. Patients on the table. Doctors next to patients. Come on. Patients facing the front, so we all do this together, uniform. This is military now. I can't hear you. I'm the DI. It's the best way to learn muscle testing. It's better to learn it military. Patients seated, doctor standing. You're either a patient or a doctor. Okay, you ready? We're going to test the middle deltoid. We bring the arm up. It's parallel to the floor. Elbows bent at 90 degrees in a neutral position. So it's not with external or internal rotation. It's a neutral. We're going to stabilize the opposite shoulder. You're going to push in a geometric arc down and in. Down and in. That's a good one. Down. That's a weak one. Down and in. Okay? Now, don't move. Bring the hand up about like so. We're going to stabilize the back of the shoulder. We're going to test the anterior deltoid, pushing in line with the arm. Anterior deltoid. Now, don't move. Bring the hand down like so. Stabilize the front of the shoulder, pushing in line with the arm. That's a good one. Okay, so that's middle, anterior, posterior. Now, elbow straight, thumb up. My thumb is on the lateral inferior border of the scapula. I'm going to pull here and push on the scapula here, and it's whether the scapula wings away from the thoracic cage. This is the upper serratus anterior. Bring it down about shoulder height. That's the middle serratus anterior. That's a weak one. Bring it down lower. That's the lower serratus anterior. So on Keith, it's just his right middle serratus anterior. It's just certain fibers. And these fibers here will be tender more than these and more than these. But these will be the tender ones. Okay, remember it first through the 10th ribs. What muscle was the first muscle? Serratus anterior, origin insertion, 1964, delivery boy for standard process. Ah! Okay, now, let's have them lay on their back. Okay, patients head this way, feet this way. We're all going to be uniform. Books, water, nose, off the table. Head is toward the window, feet is toward the door. It's a simple thing. Does everybody have a table? Okay, we're going to do a popliteus, supine. Hands off the body. Hands off the body. No chewing of gum. Rudy, meaning you. Hands off your body. Hands off your body. Bend your knee. Foot is in dorsiflexion. Tibia is in internal rotation. Stabilize the outside of the ankle, watching the tibial tubercle, pushing in a rotary fashion out. He's got a weak one here. I shouldn't do that right after you. Stabilization hand is Julie, help. Stabilization hand is to the out of the ankle. Okay, now turn them on their sides, facing the front. He's stabilized here. Middle here. Now, legs straight. Now, we're going to be testing the downside is the one we're testing. So we raise the top one up. We're holding the top one. Ask them to raise the foot up to bring it up. Don't let them rotate back. Keep the hips perpendicular. Then we're going to push down. That's a good one. You'll be surprised how many weak ones you'll find. That's weak, yeah. Okay, on your stomach. Patients on their stomach. Turn the head to the right. We're going to test the lower trap. Bring the arm up, elbow straight, up here. So we're lining up the fibers. You're going to push down. Let it go in front of the head. In front of the head. Now, do the middle. Bring it here. Thumb up toward the ceiling, pushing down and in. That's a good one. Down and in. Now, both hands up, Detroit. Not your body. Bring the head back. Cover the front of the forehead so that you don't smash their nose into the table, pushing down and in. Down and in. That's the lumbar fix. Turn the head to the right, pushing down and in. To the left, down and in. That's an iliac fix. See, so you're still not fixed. Okay, is that it? Let's switch, doctor and patient. We'll start with the deltoid. Okay, so patients get seated, please, facing the front. Doctors, prepare yourselves to test the middle deltoid. Okay. Bring the arm up so it's parallel to the floor. Forearm is neutral. Stabilize the opposite shoulder. You're going to push down and in, not straight down. Down and in. That's a good one. What they'll do when they recruit is they'll tend to go in external rotation to recruit the anterior delt. Now, anterior deltoid, bring the hand up about like so. Your line of drive is a straight down the forearm. Stabilize the back of the shoulder. That's a good one. Now, when you do that, it's take more of a contact here. You can push this one. Don't pull. Come right around to the side and do it that way. Okay, posterior delt. Bring the hand down. You're going to push right in line with the forearm. Stabilize the front of the shoulder. That's a good one. Okay, serratus anterior, elbow straight. Bring the arm up like so. It's not here, and it's not here. It's right in the middle and up a little bit. You're going to contact here. My thumb is on the inferior lateral border of the scapula. I'm going to pull down and push here. That's the upper fibers. Bring it shoulder height. That's the middle fibers. Here's the lower fibers. So we have upper, middle, lower fibers. Okay. Question? Oh, I didn't have to do the teres major. Okay, lay on your side. We're going to test the abductors, so facing the front. Okay, we're actually testing the down leg side. So we're going to bring the top leg up. You're going to hold that. Ask them to lift the bottom foot up. You're going to push the bottom leg down. You're holding this leg up. You're holding this. Ask them to raise the bottom foot up. Raise up. You're going to push the bottom leg down. Okay, we're testing the calm down. Cut back on your starches. If he's on his left side, we are testing his left adductors. Opposite the gluteus medius, right? Okay, lay on their back and let's test the popliteus supine. We'll bring the knee up, foot up and in, hands off the body, hands off the body. Stabilize the outside of the ankle, watching the tibial tubercle, pushing out in a rotary fashion. Yep. We're better fix you before dinner tonight. Okay, flip over. Okay. No, turn your hand around the other way. Okay, turn over on the stomach, head toward the window, feet toward the door. Head toward the window, feet toward the door. Okay, turn the head to the right. Bring the arm up, elbow straight, thumb up. Line up the lower fibers of the lower trapezius. Stabilize the opposite shoulder. Push down into the front. Down into the front. Now, bring the arm straight, even, thumb up. Pushing down and in for the middle trapezius. Down and in for the middle trapezius. Stabilize the opposite shoulder. Okay, watch up here for a minute. Look, here's the middle trapezius here. Here's the upper trapezius. Still stabilizing the opposite shoulder. You're going to push down and in. I'm sorry, lower trapezius, down and in. Okay? Now, let's do one that we forgot with the other group, the teres major. Make a fist behind the back. Have them raise up the elbow. We're going to test one and then both. Okay, we'll test one first. Stabilize the opposite shoulder. You're going to push around geometrically. That's an internal rotator of the humerus. Now, test them both. Two fists, not touching each other in the lower back. Have them bring the elbows together. Test it wrong first. Test it this way, then test it this way. So do it wrong the first time. Test it this way, then test it this way. The problem with AK is if you can't muscle test, you can't do AK. Okay, now this, we forgot to have the other group do that, so switch doctor-patient. Oh, I'm sorry. Lay face down. We forgot neck extensors of this group. Okay, Detroit position, hands up, head back, but not the body. Shh. Look up here, head back, but don't bring the body up. Just the head. Don't smash the nose into the table. That's a lumbar fixation. Now turn the head to the right. If that's weak, that's an iliac fixation, and if they're both weak, that's a sacral fixation. Okay, now switch doctor-patient. At least we know Rudy's pushing. Okay, we're going to test the teres major. I forgot to have you guys do that. I wanted to make sure you got a chance to do that. Let's do the right teres major. Make a fist, put it in the small of the back. Have them bring the elbow up and back. You're going to push in a geometric arc around in a circle. Now test them both. Two fists behind the back. Bring the elbows together. Test it wrong the first time. Then test it properly. Big difference. See, it's all in the arc. Yeah, I learned that from David. Okay, take your seats. Let's put the light on for the projector. Okay, now let's go through the slides. So turn your workbook to M301. It's just before the Category 1 section, I believe. This is the trapezius muscle as a group. You can see that it starts from the T12 all the way up to the occiput. Goes down over to the clavicle and then around to the scapula and back down to T12. Weakness of the lower trapezius many times will allow a forward rolling of the shoulder in a hypertonic tech minor. Here's the lower trapezius from about T12 until about T6 over to the spine of the scapula. Weakness on one side will allow a forward rolling of the shoulder and a hypertonic pec minor. A bilateral lower trapezius weakness, which is due to a thoracolumbar fixation, will many times hide a bilaterally weak pec major clavicular. Increased kyphotic curve is also many times due to a bilaterally weak lower trapezius. The lower trap, as well as the middle trap, are related to the spleen. They're on the spleen meridian. Nutrition is spleen tissue, vitamin C, and calcium. Neurolymphatic is the seventh intercostal space on the left. Posteriorly, the lamina of T7 on the left. What other organ shares the lymphatic for the seventh intercostal on the left? That's the muscle. What's the organ? Pancreas. I think the same way I get the muscles, I just think of them as one. But the gentleman up here said latissimus dorsi, that's the muscle. The organ is the last. The neurovascular, menoreflex, is 1 inch up from the lambda. What other muscle has its neurovascular 1 inch up from the lambda?
Hamstring.
Hamstrings. Okay, here's a very good slide, but the test should be maybe here and ending in front of the nose here. So the test is from here, ending here. From here, ending here. Next muscle, middle trapezius, has all the same reflexes, same organ, meridian, but it's from about T6, T5 up to about T1 over to the spine of the scapula. And here's a very good slide. Maybe a slightly more distal contact, but we're bracing the opposite shoulder and pushing down and in, down and in, down and in. So it's from here this way, from here this way. Okay, all the same reflexes, same nutrition. Upper trapezius, which you learned in session 1, comes off the clavicle. How many muscles attach to the clavicle? Anybody? Five. Name them. Start medial and go lateral. Sternocleidomastoid, subclavius, pec major clavicular, anterior delt, somewhat of the middle delt, and upper trap. 5 muscles attached to the clavicle. Comes across, goes up all the cervical vertebrae and into the occiput. Weakness on one side will show an elevated occiput but a depressed shoulder. The trapezius is related upper to the eye and ear, but it's on the kidney meridian. Did you know that the upper trapezius is related to the eye and ear, but it's on the kidney meridian? And that the upper trapezius is related to the eye and the ear, but it's on the kidney meridian. Means it's on your test, right? It says it 3 times. Now, nutrition is B and G, F and calcium, and A. Not F and calcium, but F and calcium. Okay. Somebody asked me, well, what kind of calcium is F and calcium? It's vitamin F and calcium. B and G, F and calcium, and vitamin A. Okay, neurolymphatic, over the bicipital tendon area, the TP of the atlas, and the neurovascular is above the zygomatic arch. Here's how not to test it. It's a good slide of the muscle. How do you test it? Stand opposite to the side you're testing, perpendicular to the patient. Stabilize the shoulder, reach over the top and test. And you always turn the head to the doctor or away from the muscle being tested. Okay, the next muscle is serratus anterior, the first muscle utilized in applied kinesiology procedures. So go past the category 1. Serratus anterior comes off the first through the 10th ribs, inserts into the medial anterior border of the scapula. It's a protractor and rotator of the scapula. Weakness allows the medial border of the scapula to lean away from the thoracic cage. More clear? It's for one of the lung-related muscles. There are 3: the deltoids, the serratus anterior, and the coracobrachialis. It's on the lung meridian. Nutrition is lung tissue and vitamin C. The neural lymphatics are the 3rd, 4th, and 5th intercostal spaces, T3, 4, and 5 in the back, and the neurovascular is at the bregma. Now, what fibers is Dr. Walter testing here? They're just the upper fibers. So here's the upper, middle, lower fibers. Okay, the deltoids are next. They're actually a group muscle similar to the quadriceps. And they are the abductors, flexors, and extenders, depending upon what particular portion of the muscle. So here's a very good slide showing the origin of the anterior, the middle, and the posterior delt. The middle delt and the upper trapezius are the 2 muscles that stabilize the AC joint. They're on the lung and lung meridian. The nutrition is lung tissue, vitamin C, and RNA. This is one of the 3 RNA muscles. What's the other RNA muscle? Supraspinatus, pec minor. So you have 3 RNA muscles. That's the test question. Middle, the deltoids, the supraspinatus, and the pec minor. Those are the 3 RNA muscles. The neurolymphatics are the 3rd intercostals, T3 lamina, and the Bennett reflexes at the bregma. Here's the middle deltoid. And realize that he's pushing how? Not just straight down, but he's pushing how? Geometrically towards the body. Here's the anterior delt. You shouldn't pull from here, but it's done this way so you can see the slide. You should have your arm in line with the tab and pushing, but it's still a good slide. And here's the posterior delt. You just push straight in line with the arm. You should be stabilizing on the front here, but this is just for demonstration. Still a good slide. It inserts into the deltoid tuberosity on the humerus, all 3. Okay, let's go over the neck muscles, and I'll tell you my little goofy way of remembering it, but you can use whatever works for you. The way I remember splenius muscles, splenius SP, these come off the SPs. That's the way I differentiate between splenius and semispinalis. So splenius comes off the SPs, and the capitis goes where? To the occiput, to the head. Splenius capitis comes off the SPs of the upper thoracics, goes into the occiput. The splenius cervicus comes off the SPs of the upper thoracics and goes into the TPs of the cervicals. That's just the way I remember it. Splenius comes off the SPs. Semispinalis, it comes off parallel to the SP. Semispinalis capitis comes off the TPs of the upper thoracic to the occiput. And semispinalis cervicus comes off the TPs of the upper thoracic to the SPs of the cervical. That's just what I remember. If the neck extensors are weak, then we're going to have a external auditory meatus anterior to the plumb line. The neck extensors are related to the sinuses, but they're on the stomach meridian. Nutrition is B6, B3, and iodine. When do you use iodine? Stuffy nose. When do you use bile salts? The drip, drip, drip kind of sinus. Also, you may see flashes of light before your eyes. You'll have a bitter taste in your mouth. You'll have desquamation of the fingers and the palms. The neurolymphatic is is the first intercostal space 3.5 inches out from the sternum. The posterior Chapman reflex is the lamina of C2. The neurovascular is over the ramus of the mandible. Okay, so here we're testing. Remember, the hands have to be of Detroit. What if it's weak on just one side, testing individual? That's an iliac fix. What if it's weak individual but both sides? That's a sacral fix. What if it's weak tested as a group, like that? That's a lumbar fixation. Forget that. We're going to learn fixations in a couple minutes. Okay, the popliteus. The popliteus. The origin is off the lateral distal femur, the head of the fibula, and also somewhat the lateral proximal tibia. The insertion is into the medial proximal tibia. It's an internal rotator of the tibia. Provides support to the posterior knee. Popliteus is related to the gallbladder, and it's on the gallbladder meridian. Nutrition is vitamin A, but in particular, from standard process, AF beta food. AF beta food has probably saved more people from gallbladder surgery if they listen to me than probably any other product. Sometimes it's just plain beta food, but very often we use AF beta food. Also, sometimes thick bile, you can need iodine. Remember, for thick secretions anywhere, you could think of iodine. Tell you a true story. Just had a patient come back in who had her gallbladder taken out. I told her not to do it. She came back in worse after the gallbladder surgery, and she looked like she was going to vomit any second on my carpet while I was treating her. And one of the products I gave her was AF beta food, 6 per meal. And the other product was chlorophyll, 4 per meal, chlorophyll complex. And I did fix what I found. Saw her a week and a half later, and there was no reflux at all. It's gone. Okay, the neurolymphatic is the 5th intercostal space on the right, and T5 lamina on the right, posteriorly. This is an exception to the neurovascular. The neurovascular for the gallbladder and popliteus is over the medial meniscus of the knee. So this is one time when it's not what? On the head. One of the exceptions. Now, you learned how to test it supine. This is how you test it prone. The leg comes up perpendicular to the table, but it's basically the same test. The patient does internal rotation, the doctor does external rotation. It's the same test, only this is showing prone. This is what shows in your workbook. If you learn the supine test, you can also do this test seated as well. Next muscle is the teres major. Teres major comes off the lateral inferior border of the scapula and inserts into the intertubercular groove. It's a medial rotator. It's related to the spine. It's on the governing vessel meridian. Nutrition is if there's excess perspiration, organic minerals, heavy in potassium, magnesium, zinc when difficult to taste food, zinc also with white spots on fingernails. Neurolymphatic is the second intercostal space about 2 inches from the sternum. T3 lamina on the back, T2, T3. Now there's another exception. The neurovasculars, there are 2 sets. One is at K27. What you're going to learn when we discuss switching and acupuncture is that is known as the home of all the associated points. Kidney 27 is the junction of the clavicle, the sternum, and the first rib head. The neurovascular is straight up from the zygomatic arch. It's on the temporal bone just below the parietal bone. So there are 2 sets, one on the head and the one on the body. It's another exception to the Bennett reflex. This is how we test one at a time, going in an arc. When you test 2, cross your arms and test it that way. The next group of muscles are the adductors, ADD, and the pectineus comes off the superior pubes, goes into the iliopectineal line. Adductor brevis off the lower pubes. Adductor longus also off the lower pubes. And the adductor magnus comes off the ischiotuberosity. For the purpose of this class, we learned to test it as a group test. The adductors are related to the climacteric or reproductive organs. They're on the circulation sex meridian. Nutrition is vitamin E, male or female gonadal tissue. Now, in some regards to vitamin E, depending upon the type of problem, you use cataplex E for musculoskeletal problems. I'm giving you broad, general classifications. The dry or cataplex E is used for musculoskeletal. Cataplex E2 is used for circulatory problems, like that's our nitroglycerin. E3 is used for digestive, and the oil form, the wheat germ oil, is used for reproductive. Those are just general classifications. So the dry vitamin E, the cataplex E is musculoskeletal. The cataplex E2 is our nitroglycerin, that's for angina, circulatory problems, also muscle cramps. And cataplex E3 is for digestive. And the oil-based E, the wheat germ oil, is for the reproductive. The neurolymphatic is below, beneath the areola of the nipple, posteriorly at the inferior border of the scapula. The neurovascular is on the midpoint on the lambdoidal suture. The midpoint on the lambdoidal suture. Now, what we don't do is find a weak adductor, and if it therapy localizes to the nipple, with a woman with large breasts, rub on the nipple through breast tissue. That's what we don't do. If they're large-breasted, we have the woman lift the breast tissue up, put their hand over the reflex and our hand on top of their hand, and work the reflex that way. If they're smaller-breasted, it's not as much of a problem or a man. And also, if you don't feel comfortable doing that with that particular patient, don't do it. Okay, and definitely explain to the patient what you're doing. In my office, I have an open door policy. My treatment doors are never shut. And my staff, walk in and out. Okay? So prevention is the key. So make sure the patient understands what you're doing. And you may also want to have a support personnel in your treatment room, possibly. Okay? A weak adductor can allow a genu varus and elevation of the iliac crest on the opposite side. Okay, and this is a good test for the group test for the adductors. It's the down side. The up hand is just stabilizing. This is just stabilizing. The test is here, pushing down. That's a great slide. In any elbow symptom, always check the adductors, ADD. In any elbow symptom, check the adductors. What other muscle shares the neurovascular at the midpoint on the lambdoidal suture? No, it's definitely not the adrenals.
Glute max.
Glute max. Okay. Okay, here's a very poor secondary test. This is the supine test. Okay, what I'd like to do now, I'm going to need a break already. I mean, it's totally okay if you do. Why don't we do that? Because this next section, you really have to put your thinking caps on. Okay, so let's take a 5-minute lead break, and we'll start on fixation. Definition are a locking together of 2 or more vertebrae that display on the body predictable bilateral muscle weaknesses. Whereas a subluxation, by definition, is one vertebrae out of juxtaposition in relationship to the vertebrae above and or below itself. So when we're using the term fixation, realize it's in that narrow definition of a locking together of 2 or more vertebrae which displays on the body predictable bilateral muscle weaknesses. So the way you find a fixation is by the bilateral muscle weakness. For example, bilateral glute max is an upper cervical fix. Bilateral psoas is an occiput fix. A bilateral teres major is a thoracic fix. This is all in your workbook. A bilateral middle delt is a cervical thoracic fix. A bilateral popliteus is a mid-cervical fix. A neck extensor tested together is a lumbar fix. A bilateral lower trap is a thoracolumbar fix. A neck extensor tested weak but individually, both sides, is a sacral fix. And a neck extensor tested weak on one side is an iliac fix. Bilateral toe flexors, which is not in your workbook, is a rib head fix. So you identify the area of fixation via the bilateral muscle test. Okay. Bilateral toe flexor weakness or rib head fixation. Rib head fixation. That's not in your book. Now, okay, so how do you identify a fixation? The bilateral muscle test. Now, if sometimes you can have a bilateral muscle weakness due to something else other than a fixation, but we use our tool of therapy localization to verify it's due to a fixation. For example, if we have a bilateral popliteus weakness, maybe you need organ insertion of both popliteus muscles. It's possible. But the way to tell is you would therapy localize the mid-cervicals, and if that turned on both popliteus muscles, then it's due to the fixation. However, this fixation will not therapy localize in the clear. So if you took a strong indicator muscle like the middle deltoid, it won't weaken it unless you induce motion in it at the same time. Okay? So fixations will not therapy localize to weaken a strong indicator muscle unless motion is induced while you therapy localize. However, if you therapy localize to the fixation, it will turn on the bilateral weak muscles. That's the difference. Now, you need to know basically, are you going to unlock the fixation complex from the top or from the bottom? Most of the time, you're going to have at least 3 vertebrae. Sometimes, for example, in the thoracic spine, you're going to have more, but you'll usually have minimum of 2, but usually 3. So you have 2 options. You're going to unlock it from the top of the complex, or you're going to unlock it from the bottom of the complex. One of the 2, right? And your tool of motion palpation will determine how you do that. You motion palpate to determine the upper and lower limits of the fixation. Then you go to the top vertebrae of the fixation. It's the top vertebrae that will determine whether you're going to unlock it from the top or from the bottom. So you palpate the top vertebrae, determine posteriority, anteriority side by pushing right to left, left to right, you know that basic palpation skills 101. Then you go to the facets. You push P to A on the posterior facet, P to A on the anterior facet. If the posterior facet is more stuck, you unlock it from the top. If the anterior facet is more stuck, you unlock it from the bottom. That's really all there is to it. Do you ever push an anterior or more anterior? No. So you're going to take a contact on the posterior side. You're going to take a contact one below on the posterior side, and it's a 2-hand thrust at the same time to unlock the fixation. So a subluxation can be corrected with 1-hand contact, and the fixation requires 2-hand contact. Kind of like what? A category 1, you have to challenge with 2 hands. Well, with a fixation, you've got to adjust with 2 hands. I will repeat that at least 10 times today. Okay? So, a fixation requires 2 hands to unlock it. You take a contact on the right side, you take a contact on the left side. You never push an anterior side more anterior, right? So you're always going to take a contact on the posterior side, aren't you? Okay, and it's really that simple. Let's review. How do you find a fixation complex? Bilateral muscle weakness. That'll tell you the general area, and you can confirm that by having the patient therapy localize that area and see if it turns on the muscle weaknesses. Now, you use motion palpation to determine the upper and lower limits of the fixation. It's the top vertebrae that determines whether you're going to unlock it from the top or from the bottom. You determine posterior side by pushing right to left, left to right. So you then go to the facets. You push P to A on the posterior facet, P to A on the anterior facet. If the posterior facet is more stuck, you unlock it from the top. So you take a contact on the top vertebrae on the posterior side, 1 vertebrae below on the opposite side. Use a 2-hand thrust. If the anterior facet is more stuck, you unlock it from the bottom. Determine the posterior side, take a contact, go 1 up on the opposite side. It's a 2-hand thrust. That's all there is to it. It's really that simple. I'm going to show you on several people. Okay? Keith? Did you have a bilateral teres major? Yeah, come on up. Okay, so lay face down here. Put 2 hands behind your back, make 2 fists, bring your elbows together, head down, and push. See, if I do it that way, it's easy. But if I do it this way, it doesn't show. But if I do it that way, it's easy. So don't do it this way, do it this way. See, there's a difference. Now, what are my options? From T12 to T1. Right? So we use motion palpation to determine where within those 12 vertebrae, where in that area is our fixation complex. So I'll just palpate. Right about here, it gets stuck. Right about there. So I work my way up. And then it starts moving again there. So it's right about here is the top of the complex. It's between here and here. Which vertebrae tells me how to unlock it? The top vertebrae. I'm going to push left to right, right to left. It goes easy left to right, hard right to left. So how's the spine? To the right. Which side is posterior? The left. So I go to the left facet, push P to A, the right facet goes easier, the left facet goes harder. So how do I unlock it? From the top. Take a big breath in. And on fixations, a lot of times you'll unlock it on a breath in instead of a breath out. Put two hands behind your back, make two fists, hold the elbows together. Do it again. Okay, and that's all there is to it. I can see already we're suffering from starch syndrome. Not even going to go there yet. I want you to learn it this way first. No. I want you to learn it this way first. Okay. So, from the top, we're going to go over it about 10 times. That's usually how long it takes. How do you find a fixation complex? Bilateral muscle test weakness. So, if I had a bilateral delt, where are you going to look? That you don't know yet, but it's in your book. Cervical thoracic area. Now, how are you going to determine the upper? How are you going to determine the upper and lower limits? Motion palpation. So we're going to palpate, and which vertebrae determines whether we're going to unlock it from the top or the bottom? The top vertebrae. I'm going to push it right to left, left to right. Determine posteriority, anteriority. And then we go to the posterior facet, push P to A. The anterior facet, P to A. If the posterior facet is more stuck, how do we unlock it? From the top. We take a contact on the posterior side of the top vertebrae, one below on the opposite side. It's a two-hand thrust. If it was the anterior facet, I go to the bottom of the complex, take a contact on the bottom vertebrae on the posterior side, go one up and over, two-hand contact and thrust. That's really all there is to it. It's that simple. We assume you know how to motion palpate from your school, from your classes. Okay? That's really it. Okay? Let me do another one. Did you have that, Ron? Did you have a bilateral teres major? Okay, well let's check the one. Two hands up here. I'm using the thoracics because it's good for demonstrating this particular principle. Hold together, push, push. Yeah, he definitely has it. So what am I, now that identifies it, what, as a thoracic fix, but we have from T1 to T12. So it's somewhere in here. It could be two vertebrae, minimally, but it could be a lot more than that. So we use motion palpation. Okay, he's kind of stuck here, and he keeps stuck, wow, all the way up here. So let me just kind of, okay, here's the top vertebrae of the complex. So his complex is bigger. It goes from here down to about here. So it's a lot more vertebrae involved. Okay, anybody not with me? Okay, I go to the top vertebrae, and I'm going to do what? Left to right, right to left. It goes hard right to left. Easy left to right. So it's posterior on the left. I go to the facet on the left, the posterior facet, I push P to A, and I push P to A on the right, and his anterior facet is more stuck than the posterior facet. So we have to unlock it from the bottom. So I go down to the bottom of his complex, which starts about here. Really locking here. That one's moving. This one's, so can you tell the difference here? That's stuck, this one's moving. Okay, so I take a contact on the bottom posterior vertebrae, one above on the opposite side. Take a breath in. Okay, 2 hands behind your back. Right together. Hold if you can. Okay, and that's it. Easy peasy. His fixation and his thoracics were about that long. We adjusted the area of the body that needed to be unlocked. And unlocked the whole complex. No, that's not what usually happens. That's what always happens. I did retest. Both teres major were strong. Then you either didn't adjust it right, or there possibly could be another fixation complex in the thoracic just because there are 12 of them.
Is the posterior set going to be the same on the complex was there?
Okay, his anterior facet on his first vertebrae of the complex was more stuck on the anterior facet side. So I knew I had to unlock it from the bottom. I go to the bottom vertebrae of the fixation complex. I use motion palpation to determine posteriority side. I take a contact on the posterior side. I go one vertebrae up and on the opposite side. The 2-hand thrust, usually done on inspiration. You're never going to thrust an anterior side more anterior. Your contact will always be on the posterior side for correction, whether it's from the bottom or from the top.
You're using the superior facet, that's where you're saying.
Yeah, the superior facet of the first vertebrae of the complex. Yeah, I think you guys got it. I really do. I mean, basically, that's all there is to it. Okay. Let me do a upper cervical fix. Would you mind coming up? You don't have to if you don't want to, but I think you got it. No? You want to take off your hat? And that's okay. Lay face down here. Okay. Now, when I do the upper cervical fix, I usually use a drop piece. I don't have a drop piece here. Bend here, raise your knee up. Raise it up. Push up. Nothing. Bend here, raise it up. Push up. Nothing. Now, that identifies that we have a fixation. What is it? Bilateral? I know it's a bilateral group. Where's the fixation? Upper cervical. Now, could he need like bilateral organ insertion or bilateral lymphatics? He could, right? So we could therapy localize the area, touch here, here both hands, and see if that turns on the weak glutes. And here, raise it straight up, push straight up. And when he TLs that area, bend here, raise it straight up, push straight up. Yeah. So his bilateral glute max is due to a fixation. But now watch the difference. Bring this up here. Push back. Now, TL the area. Bring this up here. Push back. See, a fixation won't TL to weaken a strong indicator unless you do what? Induce motion. So TL that and move the chin. Keep moving it. Keep moving. Wait. Keep moving it. Push back. I'm just watching to see that he was keeping the motion. Okay, do you see how it weakened it then? But it will turn on the bilateral weak muscle. That lets you know it's due to a fixation. Now, where's the top vertebrae? It's got to be C1, so that's the top vertebrae. So you don't have to worry about the upper level for this, you know it's C1. So you rotate C1. Okay, the posterior side on him is the left. Then I push what? P to A on the facet. And actually, his anterior facet is more stuck than his posterior. So how do I unlock it? From the bottom, which would be C3. So I'm going to feel C3. So I'm going to take the posterior contact C3 on the right. What's the vertebrae above? C2 on the opposite side. When you do this, I'm not going to do it yet. When you do this, you're going to thrust P to A and slightly I to F. I usually use a drop for this part in the office. We don't have the option here. So we're going to use this pillow. And actually, I got another pillow for you so we don't break your nose. First, do no harm. No, so do like this with your hands. Now, watch me. You're not going to hurt you. Put my hands like this. Put your hands on your forehead. Put your nose between the pillows. Is that okay? Can you breathe? Okay. Now, usually when you do this, you're going to do this on inspiration. So first I'm going to test it here. Is that okay if I do like that? Is that good? Okay. Big breath in. Okay. Bring this up. Knee straight, bring it straight up. Push up. Bend here. Raise it straight up. Push up. Now that one's still weak, but it's not weak bilateral anymore, so now that's weak due to some other factor. Okay? This one's okay. Bring that up. Push up. That one's okay. This one's still weak due to something else. Okay? We got rid of his upper cervical fix. Sorry?
So it will always be all 3 segments?
I can't hear you.
It'll always be all 3 segments for the bilateral?
No, it's not always 3 segments. It could be 2. It could be 10.
No, I mean for the bilateral glute.
For the bilateral glute max, it's going to be C1, 2, and 3. So you either unlock C1, C2, or you unlock C3, C2. And you determine that how? By the top vertebrae, posterior facet, anterior facet. It's the same rule all the way down the spine, except for occiput, sacrum, and ilium. Okay, any questions on that? So it takes a 2-hand contact. You're being on adjacent vertebrae. So like if I'm on T3 here, this would be T4 down here on opposite sides. Do I ever thrust anteriorly? No, I'm always going to be on the posterior side. Okay? It's really not that complicated. Okay? So let's review. How do you identify a fixation? Bilateral muscle weakness that identifies there is a fixation and the level of the fixation. We then need to know what? The upper and lower limits of the fixation complex, and we use motion palpation. It's the top vertebrae that will dictate whether we'll unlock it from the top or the bottom. So we use motion palpation to the top vertebrae, right to left, left to right. Go to the posterior facet, push P to A. Go to the anterior facet, push P to A. If the posterior facet is more stuck, we unlock it from the top. Take a contact on the posterior side, go 1 below, opposite side, 2-hand thrust. If the anterior facet is more stuck, we unlock it from the bottom. We determine the posterior side, take a contact there, go 1 vertebrae up and the opposite side, 2-hand thrust. Usually done on inspiration for fixations, usually. That's it. That's really all there is to it. For the upper cervical, for the bilateral glute max, I usually use a drop piece with that. So if you've got that, then I can show you the occiput, the sacrum, and the ilium, and the lumbars, which are a little different. Have you got the basic concept? I know the TAs are shaking their head yes, but you've been here a few times. What about the rest of the class? Okay, I think you got it. Now, yeah. Probably not a stupid question. Probably everybody else wants to ask it, but you're the one with the guts.
If you mentioned
Sometimes you get an audible with the upper cervical, sometimes not. Usually with the thoracics, the thoracolumbar, the lumbars, yeah. But upper cervicals, mid cervicals, you may not. But in the office, I use a drop cervical with that. Okay, let me show you an occipital fixation. An occipital fix, there is no top or bottom to the complex, right? Just the occiput. That's a bilateral psoas weakness. Okay, bilateral psoas. Actually, you want to come on back up, take off your watch? And your hat? Lay in your back with your head up here. Okay, let these go. So we'll test the psoas. Bring this up and out, knee straight. Bring it out. Push up. That's a weak one. Bring this up and out. Push up. That's the weak one. So that fulfills our criteria so far. It's a bilateral psoas weakness. We'll have you TL the occiput here and here. Just the occiput, not the apple. Bring this up and out. Push up. And that turns on that one. I'm not going to walk around just for demonstration, although I should. Bring it out, turn the leg out, and push up. So that turns that on. Now, does that tell me what side to adjust? No. Sometimes, both hands up here, elbows straight. Stick your tongue straight out. Out all the way, into the right. Out into the left. Doesn't show that way. So maybe it shows eyes up to the right. Eyes up to the right. Eyes up to the left. Up to the left. Up to the right. Doesn't show that way. So now you know 3 ways to check the occiput. You know, tongue deviation. You know, eyes up to the right or up to the left. And bilateral psoas weakness. And there's still other ways yet you're going to learn. But it doesn't show those 2 ways, but it does show with what? The bilateral psoas weakness. Okay? So let's try TLing just the occiput on the right now. Bring this up and out, knee straight, push up. No change there. Let's try the one on the left. Push up. But it does TL on the left. Is it okay? And we're going to we're going to palpate for the most tender trap fiber. His is pretty deep. It's right about here. And the thrust will be straight through the glabella. Knee straight, turn it out, bring it out. Push up. Now that one's still weak. This one up over here. Bring it out, push up. That one's okay. So that psoas is weak due to something else, but the bilateral muscle weakness is gone on him. Okay. Any questions on occipital fix? So what's the indicator? Bilateral psoas, and it'll turn on my TL to the occiput, and then the side will TL to turn both weaknesses on. You take the contact on the most tender trap fiber at 7, 6, 5, 4, 3, 2, 1. Take that to your contact and you thrust straight through the belt. Okay? Alrighty, moving right along. Let me go over the lumbar, sacral, and iliac fixations now. Lumbar, sacral, and iliac fixations. Let me see, you have a lot of those. Just kind of walked up. You can come up if you want. Now let's watch him walk. Could you move your chair in? Move in and move your books over so we can not worry about. Okay, now walk like you're going somewhere and not being watched. Okay, now turn around and walk like you're late for class. You're in a hurry. Now, can you see when he walks, his whole pelvis is doing the Marilyn Monroe thing? Okay? It's like definitely not a normal gait. I mean, you can see his whole pelvis, his pelvis should move how? First of all, when we walk, do you see that? Boom, bubble, boom, bubble. Okay? See that? It should move how? In 3 axes of motion. It should move this way, it should move this way, and it should move that way, and it's not. The whole thing is rotating like this. He has a severely locked pelvis. That's how you can see it. Now, come on up here, let's have you lie face down. Both hands up, and body down, but head up. That's a lumbar fix. Hold it up. That's a lumbar fix. Now I'll show you the way that I unlock those, which is a non-specific way, but works very well. Turn over on your back. Put your hands like this behind your head. Okay, and I'm going to do a nice, slow, gentle stretch. You just relax and let me do all the pulling. Don't fight me and don't try to help me. Okay, it doesn't hurt. It's nice and slow. So what I'm going to do, this is a non-specific move, but it works very well. I'm going to stabilize the opposite ASIS from where I am. I'm going to put my arm through his arm so the back of my hand is on his body, and I'm going to pull his shoulder through the opposite ASIS. Okay? As he just relaxes or breathes out. Okay? So I'm going to put my arm through here. The back of the hand is on his body. Don't help me. And let all the air out. No, don't help me. There it is. Sometimes you get a zipper effect like a rip. Sometimes you get a big pop or sometimes a clunk. Sometimes you don't get any noise at all. So I'm going to stabilize the opposite ASIS. My arm goes through his arm so the back of my hand is on his body. Don't help me. Let all the air out. Don't help me. There, that was a clunk that time. Lay face down. Both hands up. Body down, but head back. Okay, that's good. Now, hands up. Bring your head to the right. Push up. That's either iliac or sacral. Head to the left. Okay, it's an iliac on that side. It's just unilateral neck. Let's test it individually. Touch down here. Head back to the right. And that's due to a fixation of the iliac on that side. Okay, so let me see. We use motion palpation. Bring this foot up. Push back. Push back. Push back. That was it. Okay, lay on your left side. And how did it challenge? Like an ASIN. You're going to feel like you're going to fall, but you're not. I've got you. An ASIN is a disassociation of the lower SI joint, creating deep edema. It's easy to bring into extension, but hard into flexion. No, that's what I don't want you to do. Don't do anything. Okay. Face down. Both hands up. Body down, but head back. Head straight back. Push back. Okay, well, I didn't hurt him because I didn't ruin his lumbar fix. Turn your head to the right. And that shows still weak. Turn your head left. But now it's weak on both sides. So I fixed that, but now what have I got? A sacral fix. See how one fix can hide the other? But let the body guide you as to how to do it by the roadmap. It'll give you the directions if you know how to ask it in the right way at the right time for the right person. Both hands up here. We have them touch just the sacrum. Head back into the left. Push up if you can. Head back into the right. Push up if you can. Okay, so it's a sacral fix. Now, you just go right to the sacrum as if you're using a vertebrae. You go to S1 tubercle, you push right to left, left to right. It goes easy right to left, hard left to right. So the posterior side is on the right side, and you go on the posterior sacroiliac, push P to 8. Go on the anterior sacra, push P to 8. And it's harder to push P to 8 on the anterior side, so it's the left sacral anterior fixation. When you have that, you need to do that in both sides up. And you're going to push back through the shoulder, use the spine as a lever to bring back the anterior sacrum. Lay on your right side. So it's an anterior fix on the left. That's the side that goes up. There's no kick involved, but I'm going to stabilize. Okay. The thrust is going to be back through the shoulder. I'm going to stabilize the downside. There it was. Lay face down. Both hands up. Head back into the left. Push. Head back into the right. Push. Head straight back. Push. Okay? So you've seen sacral fix, that was an anterior sacral fix. You've seen an iliac fix and a lumbar fix. Now go walk. Did you have your glasses on before? When you walk? Okay. Walk like you're in a hurry to class. Can you see how that's loosening up now? It's still rotating as a unit, but not as bad. Yeah, it's better. It's starting to move individually now. Keep walking. Fast. Fast walk. Yeah, it's still a little bit locked, but not as bad as it was. It's starting to, you can see it's starting to loosen up. Okay. And you're going to come back up in a minute because I'm going to ruin all that work by having you think about something. But before I do that, are there any questions about fixations? You've seen sacral, iliac, lumbar. You know thoracic. Thoracolumbar is bilateral lower trap. Cervical thoracic is bilateral delt. Mid-cervical is bilateral popliteus. Upper cervical is bilateral glute max. Occiput is bilateral psoas. Hang on. Any questions over what we've covered so far? How to find it, how to fix it. How do you find it? Bilateral muscle test weakness. Okay? How do you fix it? Find the top vertebrae of the fixation complex and right to left, left to right. Go to the posterior facet, push P to A, anterior facet, push P to A. If the posterior facet is more stuck, you unlock it from the top. Taking contact on the top vertebrae on the posterior side, one vertebrae below on the other side. Two-hand thrust. If the anterior facet is more stuck, go to the bottom vertebrae of the complex, determine posterior side, take a contact on the posterior side, go one up in the opposite side, two-hand thrust. Usually done on inspiration. Yeah, I will. Okay. Any questions on what I just said as far as top, bottom, posterior facet, anterior facet, two-hand contact? Okay. On the sacrum, you're going to coaptate it the same way. You're going to go to S1 tubercle, right to left, left to right. If it's easy right to left and hard left to right, which side is posterior? The right side. So it would be like this. Then you push P to A on the posterior facet side on the right, P to A on the anterior facet side on the left. If the anterior facet side is more stuck, it's an anterior sacral fix, which is what you have. That's the side that goes up. So the anterior side is up. You stabilize the posterior side down. You thrust back through the shoulder, and through a lever, it brings it back. Because you can't get on the front of the sacrum and push it A to P, right? So you've got to use a long lever. I'll do another one. I know there's another one in here. occipital fix is a bilateral psoas. Determine the side with TL. Take your contact on the most tender trap fiber, thrust through the glabella. Bilateral toe flexor weakness is a rib head fixation. Yeah.
All your cervical fixations are done with the drop.
All of my cervical fixations in my office are done with a cervical drop except the occipital fix. Will a fixation therapy localized in the clear to weaken a strong indicator? No, unless what? Motion is induced. Will a fixation therapy localized to turn on the bilateral muscle weakness? Yes. I think you got it. You just have to workshop it now. Do you want to see any of those done again? If you do, I'll do it. If not, I won't. And if you do, which one? Speak up. It's okay. No, yes, maybe. Sacrum. Ilium, you just do like a category 2. It's either going to be PI or AS, and you just challenge it. Okay, that's easy. Sacrum, if it's posterior, you know that one. I think you're a little hung up on the anterior, and you probably have one, so come on up. Take off your watch if you would. I don't know whether he does or not, but usually the guy that asks the question has the problem. Okay, slide face down. So how do we test the neck extensors? Detroit, head back, push back. Well, it's not a lumbar fix. Push up. We got a possible head left. Don't we have a sacral fix? Probably. Let's see. Touch your hands down here in the sacrum, both. But don't let them touch each other. And don't let them, no. See, this is some of the mistakes that I'm saying in workshop. ETL with both hands touching and over also the ilium. You have to be more specific than that. So I want you just to TL the sacrum, but don't let your hands touch each other. There you go. Bring your head back into the right. Push up. Left. Push up. Yeah, it says it's due to the sacrum, doesn't it? Okay. So now what do? I'm going to palpate it S1. So I go left to right, right to left. He goes easy right to left, hard left to right. So it's posterior on the right, anterior on the left. I now push P to A on the posterior side and P to A on the left anterior side. It goes harder P to A on the anterior side, so it's a left sacral anterior fix. That side goes up. Lay on your right side. Is it okay? Okay. You're going to feel like you're going to fall, but you're not. I got you. Okay. So which side is anterior on him right now? The up side. So I palpate here. There we go. Just relax. There's no kick, but I'm going to stabilize here. I'm going to roll it towards me. I got you. Stabilize the downside. Thrust back. Lay face down. Both hands up here. Head back into the right. Push if you can. Head back and left. Push if you can. Can you also see he's turning his head more even now? Before he could turn it more one way than the other, now it's more even. Okay. You needed that, so it's good you came up. And just really release. Okay. How about a lumbar fix? You want to see that again? Okay, come on back up. You may or I don't know, you may or may not have a list, but you're up here, so let's lay face down. Both hands up, head straight back, push back. No, I don't find that on him. No. Okay, you're laughing. Come on up. Come on. Never sit in the front, never laugh, never volunteer. Only laugh when I tell a joke. Come on. Lay face down. Both hands up here. Head straight back. Push back. Okay, what is that? That's a lumbar fix. Turn over on your back. I use a non-specific move for that. This is also good for lumbar anteriorities. Put your hands like that behind your head. I'm going to do a slow, gentle stretch each way. And you just relax. Don't fight me and don't try to help me. Okay? I'm going to stabilize the opposite ASIS. I'm going to put my arm through her arm so the back of my hand is here. And I'm going to pull that shoulder towards this ASIS. Just relax her. Let all the air out. There it was. That was more of a ripper that time. Okay, just relax her. Let all the air out. Don't help me. That was nothing on that side, so it's just the one side. Lay face down. Patients love that move. Both hands up here. Head straight back. Push straight back. Okay? Lumbar fix. All right? Now, if the fixations come back weight-bearing, the patient needs octacosanol, which is a long hydrocarbon chain found in wheat germ oil. If you recheck the fixation weight-bearing and it comes back, the patient needs octacosanol, which is the anti-gravity factor, so-called, found in wheat germ oil. So, let's see. Come on back up. Take off your watch. We'll just see if you have that or not. Okay. That way. Bring your head back. Yeah. Push. Oh, that's pretty good. This way. Oh, once you come back. If it hadn't come back, then you would give them wheat germ oil for the octacosanol portion. That way. Bring your head back and this way. And push. There it is. See, we'd already fixed him. Okay, so you would give him wheat germ oil 3 a day for about 21 days. I think that pretty well sums it up. Are there any questions, or what I thought we'd do is workshop it and then go through the slides, and then I'm going to show you the most important fixation there is, which is not in your workbook. But I don't want to tell you about that one first, so I want you to workshop these ones. I want you to get the basics. So let's go over it. Bilateral psoas is occiput. Bilateral glute max, upper cervicals. Bilateral popliteus, mid cervicals. Bilateral delt, cervical thoracic. Bilateral teres major, thoracic fix. Bilateral lower trap, thoracolumbar fix. Bilateral neck extensors tested together, lumbar. One side, iliac. This way, sacrum. Toe flexors, rib heads. Okay, I think you got it. Which vertebrae tells you how to unlock it? The top. Posterior facet from the top. Anterior facet from the bottom. Do you ever thrust anterior more anterior? No. You always take a contact on the posterior side, go the one up on the opposite, if it's from the bottom, or take the posterior from the top, go one down opposite. It's a two-hand thrust, usually done on inspiration. Okay, so here's what I'd like you to do on this workshop. Get with your buddy and check each other for all the fixations. Psoas, glute max, popliteus, middle delt, teres major, lower trap, neck extensors, and then fix what you find. Okay, the TAs will be walking around to help you with that. Let's take a good, let's make this a real good workshop for 25 minutes with a wee break. Is that good? Good? Okay, so let's just recap. Then we're going to go through the slides So you get it like 3 or 4 times. And then I'm going to teach you the most important fixation there is. Okay, which I held back for a reason. Okay? So, how do we identify a fixation complex? Bilateral muscle weakness. That'll also tell us the relative area of the spine that's involved. Now, how do we determine how to unlock the complex? Right, the top vertebrae. We use motion palpation to determine the upper and lower limits. We go to the top vertebrae, right to left, left to right, determine posterior, anterior side, push P to A on the posterior facet, P to A on the anterior facet. If the posterior facet is more fixed, we unlock it from the top by taking a contact on the top posterior side of the vertebrae, and then the one below it to the opposite side, 2-hand thrust, usually on inspiration. If the anterior facet is more locked, we go to the bottom vertebrae, take a contact on the posterior facet side, go one up, opposite, bilateral thrust, usually on inspiration. That's it. We go back and recheck our bilateral muscle weakness, which should now test strong. If only one tests weak, that could be due to some other factor. But the bilateral weakness should be gone. Will a fixation therapy localized to weaken a strong indicator muscle in the clear? No, unless motion is induced. And will a fixation complex therapy localized to turn on the bilateral muscle weakness? Yes. And what if the fixation comes back on weight bearing? Octacosanol found in wheat germ oil. It's a long hydrocarbon chain, the so-called anti-gravity factor. Okay? Okay, let's get the slide on, and we'll go through the slides. So a subluxation and fixation are really a horse with a different color. Fixations are a locking together of at least 2, but usually 3 or more vertebrae. A subluxation is one structure out of juxtaposition with the vertebrae above and below. Whereas a fixation are 2 or more structures involved. Is that a little better? A subluxation can produce variable muscle weaknesses. A fixation produces specific reproducible bilateral muscle weaknesses. A subluxation will therapy localize in the clear. A fixation will therapy localize when motion is induced. A subluxation will challenge with one vector of force. A fixation will challenge when a vector of force is placed into at least 2 vertebrae. So do you remember category 1, how you had an opposite TSS and ischio-tube contact? You can also challenge a fixation by taking a contact opposite sides and contiguous vertebrae at the same time. So you can challenge a fixation. But I wanted you to learn it by using the motion palpation method because you needed to know that as well. But you could always verify it with a challenge, but it requires 2-hand contact. A subluxation may be able to be visualized on static X-ray, but a fixation you're going to need to take motion X-rays. Now, if I bend my head to the right, which way should my SPs go in the cervical spine? Left. If I bend my lumbars to the right, which way should the SPs go in the lumbar spine? To the right. A subluxation can be corrected with one contact. A fixation requires contact on 2 contiguous vertebrae on opposite sides. Do we ever thrust an anterior side more anterior? No. We always contact on the posterior side for contact. Okay, here are the muscles. Psoas for occiput, glute max for upper cervical, popliteus mid-cervical, middle pelt, cervical thoracic, teres major thoracic, lower trap thoracolumbar, neck extensors together lumbar, neck extensors separately but both sides sacral, and unilateral neck extensors sacroiliac, bilateral toe flexors rib head. So to determine if the fixation is due to a bilateral muscle weakness, we can have the patient therapy localize it, and it will turn on the bilateral muscle weakness. So find the fixation complex via motion palpation. Top vertebrator is indicator of where to correct. Push left to right, right to left. So here it is hard left to right, so it's posterior on the right. It's easy right to left. We then determine resistance at the facet of the top vertebrae. Posterior fixation, you unlock it from the top. Anterior fixation, you unlock it from the bottom. Is that 10 times yet? It's got to be close. Just read through that and see if you come up with the conclusion at the bottom. If you do, you got it. If you don't, get help. Everybody got it? I don't know how to say it again in this, a more simple way. That's about as simple as I can make it. Okay? So in this case, we would unlock it from the top. Right posterior fix. Occipital fix, bilateral psoas. Take a contact on the most tender trap fiber, thrust through the glabella. That's what we saw walking up and down the hall or the aisle. Does that look more clear? Okay. See if the automatic focus is on, because somebody may have, I should not have to refocus that after every. There's a little thing there, it should be on automatic focus. Okay. So we push on S1 tubercle, right to left, left to right, as if it were an SP. We push on the sacroiliac, on the posterior side and the anterior side. If it's a posterior fix, we take it from the posterior side. If it's an anterior fix, we take the anterior side up. We thrust back through the shoulder while stabilizing the down side. So which side is anterior here? The left side. He's stabilizing the right sacrum, but he's thrusting back through the shoulder. He's using the spine as a lever to bring it back. Okay, that brings us up to our most important fixation. We can get the light back on the projector. And before we do the limbic fix, any questions for the last time on fixations? You guys feel pretty good about it? I think you guys have gotten that easier than any other class I've ever taught. So you're to be congratulated. Okay, yes, give yourselves a hand. Now, take your handouts out and turn to where it says limbic C7 first rib head fixation. And I'm going to be going right down the back of that, down the flow chart. Now, the deer comes to the edge of the forest. He sniffs to the right, and he sniffs to the left. You therapy localize the T1, C7 area. It should not weaken a strong indicator muscle. You then have the patient turn their head to the right, turn their head to the left. If they weaken, they have a limbic fix, which is a fixation between C7 and the first rib head. You then challenge C7 and the first rib head away from each other. That will give you the direction of correction. Usually you have to do it in 2 moves. This will be associated with weak ankle muscles, but all on one side of the body. It's all in your handout, but you can write it if you want. It's associated with weak ankle muscles, all on one side. Dr. Goodhart calls this a limbic fix because he feels it affects the limbic portion of the brain, thereby especially involved in emotions. There also sometimes is a lower limbic fix between L1 and T12 ribs. That's not as common. And you find it the same way. You therapy localize the area, have them turn their head left, have them turn their head right. The muscles that are involved are either the serratus posterior superior or the serratus posterior inferior muscles. Oh, could you, thanks, Steve. You scared me for a second there. This box appeared out of nowhere. I was like, I wonder if everyone sees that. I hope they do. Okay, because I see it. All right. So the serratus posterior superior is related to C7 first rib. Serratus posterior inferior is related to L1 T12 rib. Come on back up. Take off your watch. Now, we had corrected a lumbar fix, an iliac fix, and a sacral fix. So let's just see if that helps. We'll have you lay face down here. And put both hands up here. Head back. Yeah, that's good so far. All the way up. And that's good so far, right? Right. Yeah. So far, so good. Yeah. Now, if he does weaken when he stands, did you take some weaker oil? Okay, come on, stand up. Let's just check him standing. See, face that way if you would. Bring your head back. Push back. Okay, and then head back and left. Yeah, so the wheat turmoil, and right? The wheat turmoil didn't take care of that for you. Okay, now, lay on your back. Both hands up here. Hold real hard. Now, how are things at home? Okay, so get a mental picture of home. Okay, that's enough. It's gone. It's back. Lay face down. So how long does that last? As long as he doesn't go home, he's okay. Or maybe you're not ready. Try again. 1, 2, 3, go. How long does that last? Lay up, turn over on your back. What you'll find, if he has what I think he has, hold your foot up and in. That one's okay. Now, I know you don't know the ankle muscles yet. We're going to learn that next month. Okay? But get the idea of what I'm doing. Hold the foot up and in. That's the anterior tib. Hold it up and out. Now scoot up a little bit. Hold the foot down and out. Hold it down and in. So he's got all the ankle muscles weak on this side, but not this side. Probably has a limbic fix. Lay face down. Okay, now hold this up here. Push back hard. Bring this one up here. Push back hard. Okay, we'll use this one. Put your head straight and touch here and here. Let me have your hands. So we're going to the C7 first rib head area. Bring this up here. Push back hard. Now, what if it weakened just on TL? That's a subluxation. You just challenge and adjust, but it didn't. But what if it did? Now, Turn your head to the right. Push. But when he turns his head to the right, then he weakens. Turn your head to the left. Push. 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 Turn your head to the right. Push. Okay? So that's a limbic fix. The deer comes to the edge of the forest. He sniffs to the right and he sniffs to the left. That doesn't tell you how to correct it, but that it's present, along with weakness of all the ankle muscles on one side only. So now we're going to challenge. It requires a two-hand challenge. Head down. Arms down. Is it okay? So I go to C7. I'm going to challenge C7, left to right, first rib, right to left. Push up, and that's the way it challenges. So I need to take the first rib this way, C7 that way. Okay? Before I do that, let's check them for the other fixation. Raise that up. Push up. Push up. Push in. Are you trying? Wait. Push in. Your head this way. Arm up. Elbow straight. Thumb up. Good. Hold it up. Good job. Other way. Way up. Push up. Okay. You put two fists behind here. Put your elbows together. Push, push. Maybe you're not ready. Push, push. Sit up. Face that way. Hold this up here. Push up. Push up. Try again. Push up. Yeah. Lay your back with your head up here. Bring this up. Hands down. Bring this up. No, not that. Knee straight. Push up. Ceiling. Push, push. Try. Yeah. Push, push. Okay, so he has all the fixations so far that we've learned. Okay? But I corrected the iliac, the sacral, and the lumbar fix earlier, and it did hold until we had him stand. The wheat turmoil corrected that. But as soon as I had him think of what? Some kind of an emotional event somewhere, everything just blew out again. Now, no questions yet. Let me have you lie face down. Let's correct that. Okay, so the first rib challenge, right to left, C7, left to right. So I'm going to take the first rib first. Is that okay? Okay, turn over on your back. I'm going to take 7 supine. Let your leg down. Okay, lay face down. Now, touch here and here. Bring this up. Push back. Turn your head to the right. Push back. Turn your head to the left. Push back. Okay? Now, go for a walk. So I adjusted first rib head in C7. Can somebody move that chair in so he has a clear runway here? Thank you. How does that feel? Yeah, different. Yeah, go ahead. Walk fast. It's much better now. You even do a light jog, can you? So, yeah, do a light jog. And then back. Jog. Yeah, go. Yeah, starting to. Okay, come on back up. Lay on your back with your head up here. Hands by your side. Hold this foot up and in. Push up if you can. Hold this up and out. Push up. Hold this down and out. Push up. Hold this down and in. Push it. That's different. What's the dumbest thing you could do? Somebody comes in with ankle symptoms. only, right? It could be there, but you've got to look at the thing that it's attached to. Hold this up here, knee straight, push up, push up. Knee straight, push up to the ceiling, push up to the ceiling. Come on up. Some of you, when I tell you to push, I don't feel any pressure that you're pushing. This up here, sit up straight, push up. Push up, push up. That one's weak, that's due to something else. The bilateral weakness is gone. Lay face down. Bring your head this way. Hold this up, elbow straight, thumb up. Push up. Turn this way. Elbow straight, thumb up. Push up. Hands up, Detroit. Head back. Push back. Turn your head to the right. Push up. Turn your head to the left. Push up. Hold this foot down and in. Down and in. Push in. I'm going to go out. You push in. That one's still weak. Hold this one down and in. Pull it. But the bilateral weakness is gone. Bring that straight up. Push up. Try not to kick the doctor. Bring that up. Push up. Okay. All the bilateral weakness is gone. I don't know. I didn't get that far yet. If you make an elephant disappear, then don't ask where the feces to the elephant went. It's good enough the elephant went away. Now, the thing you should also check is for the lower limbic fix. So we'll have them TL what? L1 T12 rib. You can do palms up if you want. Bring this up. Is that over right? Push back hard. Turn your head to the right. Push. Turn your head to the left. Push. Push. Push back. Okay. He doesn't have the lower, but he had the upper. But if he did have the lower, you would just check L1 T12 rib, same as you did up here. It's a two-hand challenge. Okay? Pretty good. Don't act too surprised or, turn over on your back. First time I saw that, I think my mouth hit the floor. Now, elbow straight. Elbow straight. Okay, how are things at home? Think about home. Every house in your home. Okay? I don't know what to do after that to impress you because I got nothing left. That was it. Okay, so the deer comes to the edge of the forest. He steps to the right and he steps to the left. So what's the first fixation you think you might check for? Go right for the limbic. Go right for the limbic. That's why I showed it to you. Do that one first. Go to the limbic fix. And that's all written down for you in your handouts. Okay? All the ankle muscles will be weak on one side only. TL the C7, first rib area. Have them turn right, have them turn left. If not, have them check the L1 T12, turn right, turn left. Okay? Any questions on limbic fix? How many here that have taken the course before have found that to be valuable? Okay. All right. You get the thanks. And we got plenty of time, so let's cover the next topic, which is another biggie. This sessions 1, 2, and 3, and 4. I mean, you could build an entire practice just on each in any one of those sessions, but to put them all together is phenomenal. These are all the biggies in AK. Fixations are biggies, especially that limbic fix. So turning your workbook to the iliocecal valve, And what I tell patients is that if blood sugar, water metabolism, and ileocecal valves are functioning properly, you're going to do pretty good most of the time. And when one or more of those three aren't functioning properly, you're not going to do too good. So it's one of the three of the basics to health: blood sugar, water metabolism, and ileocecal valve. Now, the ileocecal valve is the valve that connects the small and large intestine. It's meant to be a one-way valve for the food bolus to go from the small intestine into the large intestine, and then it closes to prevent reflux back up into the small intestine. Its location is at very near to McBurney's point, about midpoint between the umbilicus and the ASIS. For those that are interested, here is the human ileocecal valve research, or some of it anyway. You can write those down if you want. I'll give you a moment to copy those. Okay to change? Anybody still writing? If you are awake, it's no problem. Okay to change? And here's the animal ICV research for those interested in that. Okay? All right. Now, ileocecal valve syndrome, so it can be the great mimicker. This is definitely not an all-inclusive list, but shoulder pain, especially of a bursitis type, worse at night when you lay down, acute hot low back, pain around heart, dizziness, flu, bursitis, sacroiliac, tinnitus. Almost all tinnitus, in my experience, are the ones almost all tinnitus are the ones I treated.
I got a formal dinner to attend tonight.
Ah.
I wish everybody a very Merry Christmas.
Merry Christmas, Gary. Looking very sharp.
Good night.
Almost all tinnitus is related to ileocecal valve. Constipation, if it's a spastic type. Diarrhea, if it's an open type. Nausea, faintness. Sinus problems. Headache, definitely. Sudden thirst, pallor, dark circles under the eyes. Carpal tunnel syndrome. Many, many things. It's just one of those things that I would say check on every patient, every visit. That's what I do. Now, basically there are two kinds. There's an open or a closed. The best way to do it is have the patient TL with two hands to ileocecal valve. If it's positive, have them push in, pull up, and hold towards the left shoulder. That closes the valve. So if that negated the TL, that's an open ileocecal valve. If a TL is here and pushing down and holding out negates the TL, that opens it, so they would have a closed ileocecal valve. Pulling up closes it, pushing down and out opens it. So start with a positive TL, find what negates it. If pulling up negates it, it's open. If pushing down and out negates it, it's a closed, or what we call spastic ICD. I think that's the best way to do it. Now, I'm going to be based on this page here. That's the page I'm on. So, S004-02, there's a mistake on here. Actually, there's a couple of mistakes on here, but let me see yours and make sure that they didn't correct them. Is this yours? They may have corrected it. No, they didn't. Okay. So, for the open ileocecal valve, the neurolymphatics are, as the workbook says, over the right bicipital tendon area, just below the right ASIS, and then C2, C3 area on the right in the neck. Those are the lymphatics. The neurovascular is almost right over the valve. The acupuncture points are kidney 5 on the right, which is just below the medial malleolus, bladder 58 on the left, which is between the gastrocnemius and soleus muscles, about 2.5 hand widths up from the lateral malleolus. Kidney 5 on the right, bladder 58 on the left. In your workbook, it shows bladder 58 on the right. That's incorrect, so put an X through that. The subluxations are C5L1, C5L1. The nutrition is chlorophyll. The muscle involvement is iliacus. Okay, so the lymphatics, the vasculars are as shown. It's kidney 5 on the right, bladder 58 on the left. That's 2.5 hand widths up from the lateral malleolus between the gastrocnemius and soleus muscles. The subluxations are C5L1. Those are the lovets to each other. The muscle is the iliacus. The nutrition is chlorophyll. For a spastic or closed ileocecal valve, the neurolymphatics are for the quadriceps, the costochondral cartilage. It's not kidney 5, so put a cross through your workbook where it says kidney 5 for the closed ileocecal valve. It's bilateral bladder 58. Bilateral bladder 58 for a spastic. The subluxations are C3L3. The nutrition is calcium, like an ionizable form, calcium lactate. The muscle is the quadriceps. The muscle is the quadriceps. I'll demonstrate those up here in a little bit. Okay, now you basically can have an open or a spastic ileocecal valve. You can think of that as a good way to determine if there's too much or not enough. Too much tone would be a spastic ileocecal valve. Not enough tone would be an open ileocecal valve. So it's a good way to kind of tell in that person's body whether they've got too much sympathetic or not enough, or too much parasympathetic or not enough. For the open ileocecal valve, they tend to be too alkaline. They may need HCl, definitely chlorophyll. The spastic or closed, they tend to be too acid. You may think of pancreatic enzymes, definitely calcium. The open would be too much parasympathetic. The spastic would be too much sympathetic. So again, you could go back to that adrenergic, cholinergic, and the open, you may need whole adrenal. For the spastic, they may need colon. See, the ileocecal valve is under what? Neural and hormonal control, both. So this is important. No popcorn, chips, nuts or seeds, spicy foods. If it bites the tongue, it bites the intestines. No alcohol for temporary. If you do drink, after you get over this, you should drink not more than twice a week and never drink 2 days in a row. And not too much caffeine. Coffee is okay, or tea with breakfast only, but no chocolate. So no popcorn, chips, nuts or seeds, spicy foods, alcohol, chocolate, and caffeine. I usually don't take them off raw fruits and vegetables unless there's somebody who was just converted to vegetarianism. And they've gone kind of a little too far, and they're eating only raw fruits and vegetables. And they come in with a hot disc or whatever. Dark circles under the eyes like they're carrying coffee grains under the eyes. That's a pamphlet that I probably use more of than any other pamphlet. Okay. Now, let me do one of these on somebody. If you wanted to do a comprehensive digestive stool analysis, you can do that through one lab is Great Smokies Diagnostic Labs. Their number is 1-800-522-4762. 1-800-522-4762. Great Smokies Diagnostic Labs. There's something I learned from Scott Walker, and he calls it APES. Don't let the APES get you. And that's an acronym for allergies, parasites, and emotions. Those are things that will cause a chronic ileocecal valve. Allergies, parasites, and emotions. APES. Allergies. Wheat, dairy, corn. Wheat is pec major sternal, dairy is psoas, corn is supraspinatus. Remember we went over that? Parasites. You can get parasites from sushi, but also from almost anything. That's why I recommend you drink distilled water. It's becoming more and more of a problem. You can get parasites anywhere in the body. Some good antiparasitics are Zymex 2 from Standard Process. Zymex 2. Artisan from Thorne. Artisan. Berbercap from Thorne. Citruside from Thorne. Entracap from Thorne. Garlic from Standard Process. Okay? When you take an antiparasitic, you got to take it for 2 months in between meals. not with food. Otherwise, the enzymes are used to digest the food, not the critters. You usually need to take it for 2 months to get it through a life cycle of laying eggs. So you take it for 2 months, not 1 month. Just varies. Varies. I've used as many as 21 a day in some patients, as high as that. And I've used as little as 3 a day in other ones, so it's variable. Okay? Don't eat sushi. Don't eat raw meat, like carpaccio or steak tartare. Okay? Unless you know the source. Okay? Allergies, wheat, dairy, corn. Emotions. You can just simply cross key out the emotionals. Okay? And then just hold them and wait for what? Synchronization of the pulses. Remember, they beat at 72 beats per minute. Remember, the skin and nervous system both come embryonically from the ectoderm. Okay, so allergies, parasites, and emotion. That's a pretty good one. That was very helpful for me with my patients in my practice. Okay, so let me do one of these. You'll find this very often, for example, in an acute hot disc. You want to think of ileocecal valve, carpal tunnel, bursitis of the shoulder, even a heart pain very often, flus, colds, sinus problems, an SI joint pain. Very common problem. So let me kind of take one of these. Anyone think they may have this, or? Okay, we've already used you quite a bit, so let's let that settle in a little bit. Okay, what are your symptoms? How do you know you got a cold? You've been checked? Okay, what about you? Come on up. Take off your watch. Your glasses. Okay. Now, take them. Okay, those aren't shoes, so get rid of those things. Okay. They're good for cooks. Lay your back with your head up here. Now, I'm just going to take a strong indicator muscle. I'm going to push down, you push up. Okay, so that's a good strong indicator. We're going to have him TL between his ASIS and his belly button. So we're going to go right about here. We're going to go right hand first, and then the left hand on top. Don't push in, but just touch. Bring this up here, push up. Now when he TLs that, we get a positive TL. Does that tell me whether it's open or closed? No. So what I'm going to have him do is I'm going to have him push down, pull up towards the left shoulder. I'm going to let go, but you hold that. So you hold that, I'm going to let go now. So when I let go, you hold that. And I tell them that about 3 or 4 times, and over half of them still let go. Hold that up, I'm going to let go now. You hold that. Okay. Keep holding that. Push up. Now when he pulls up, that negates the TL. So what does he got? He has an open ileocecal valve, because pulling up towards the left shoulder and holding it statically closes the valve. So he has the open variety. Okay? Now, where are the reflexes? Right? Over here, C2, C3 area, bicipital tendon, below the ASIS, those are the neurolymphatic. Where are the subluxations? C5, L1, what's the nutrition? Chlorophyll is the main one. Okay? And we have kidney 5 is here. And bladder 58 is here. 1 hand, 2 hand, half a hand between the gastroc and soleus. Right there. Okay? So let's go ahead and do that. What's the muscle that should be weak? The iliacus. Now, we can test that in the midline, full external rotation, push straight up. We can test it that way, but if a patient has a hot disc, can we do that? No. So let me show you the prone test for the iliacus. Turn on your tummy. The prone test is you bring the foot straight up, let it drop out. Don't let me push in, you push out. That's the prone iliac test. Push out. It's sort of opposite the what? Piriformis test. Okay? Turn over on your back. Okay? So we can work these reflexes. Usually they're pretty tender. Okay? Now, if we wanted to check it for food allergies, we could take a strong pec major sternal, a strong supraspinatus, and a strong psoas. Check the pec major sternal against wheat. Check the supraspinatus against corn. Check the psoas against dairy, which I would recommend you have that done. That's the allergy part. What about parasites? We could put a little Zymex 2 and see if that strengthened the weak iliacus, couldn't we? So why don't we do that? Okay. Now it's a capsule, so I have to open it up. Lift your tongue up, please. Get a taste of that. That's Zymex 2. Knee straight, turn it all the way out, push up. So if I were you, I would take non-Zymex 2 in between meals, 3, 3, and 3, for 2 months. Don't eat sushi. Or if you do, eat the cooked, the unagi and the California roll, that kind of thing. Okay? So don't tell them they have parasites. Don't tell them they have parasites unless you want to do a CDSA and they miss it over half the time anyway. Just tell them you're going to give them this to help clean up their colon, which is the truth. Okay? You're not lying, but don't tell them they have parasites because some of them freak out and they're going to go to a parasitologist. And then, okay? Now, what's the other one? Emotion. So swallow that. I'll give you some water here. Drink out of this. And bring this up, push up. Put your hand on your forehead. Push up. Yeah, not related to this anyway. Let's try it from down here. Try just the pad with your fingers here. We'll bring this one up. Enter. Push up. Put this hand over your forehead. Push up. Push up. Yeah, not for this. Doesn't show for this. Okay? So mainly I would get checked for the foods, which we didn't do, and I would definitely take that Zymex 2. And if you eat sushi, I wouldn't eat it anymore if I were you. Okay? We can work the reflexes. These will be tender. Okay? We can work the reflexes here. These will be real tender. Okay, now I would do it much longer, but I'm just for, and then below the ASIS, this one's usually not as bad. Some people find this ticklish. But, okay, to do the kidney 5, what I would do is you could tap it. Inferior medial malleolus, you could tap it. You could also laser it. Bladder 58. 1, 2 and a half. Between the, notice I sit on his foot and I hold his leg. Do you think I've done this before? That's bladder 58. Okay to do that? Okay, C5 and turn over on your tummy. What goes to C5? L1. Hold this foot up here. No, just bend the knee. Push back. Push back. I'm going to see if it's anterior. So I'm using a static challenge, and on him it is. Turn over on your back. Put your hands behind your head like that. I'm going to do a slow, gentle stretch. Let all the air out. There it goes. And get an element through here. And let all the air out. There it was. Okay, I don't even need to reach out. I could feel it. It moved good. Knees straight. Turn it. Push up if you can. Okay. And let's have you feel the here, bend here. You push up, I push down. Okay? That's right. No popcorn, chips, nuts or seeds, spicy foods, alcohol, chocolate, or caffeine. Great details. Okay. And I definitely would take that Zymex 2 9 a day for 2 months in between meals. Okay, you're welcome. I would work those reflexes longer. I just didn't do that for demonstration for time purposes. Okay? Big stuff, yes.
Would the body consider onions and garlic to be spicy?
No, onions and garlic usually are fine. Yeah, those are actually good for you. Garlic is a real broad spectrum anti-everything. Antivirus, antibacteria, anti-parasite, anti-cholesterol, anti-worm. Yeah, it's just a great, great thing. Hey, any questions on ileocecal? That is one of the biggies. So one thing you may want to add to your growing list here now is ileocecal valve. I personally check that on every patient, every visit. The calcium for the spastic ileocecal valve, calcium lactate works just fine. Don't let the aches get you. Allergies, parasites, and emotions. Don't let the aches get you. Yes? I don't put that on for a short period of time. I tell them no popcorn, chips, nuts or seeds, spicy foods, alcohol, chocolate, caffeine is okay, but only with breakfast. If you drink, only drink twice a week and don't drink 2 days in a row. That's a permanent diet for I help my patients. Spicy, if it bites your tongue, it bites your intestines. Yeah, and I tell them no sugar, no pies, cakes, cookie, candy, ice cream, soda pop, donuts, brownies, no bread, pasta, rice, or potatoes. Bread, pasta, rice, and potatoes. Eat protein 3 times a day. Beef, fish, chicken, turkey, pork, lamb, and eggs with veggies. Any kind you want except taters. Fruit in between, but not fruit juice. It's okay to mix your fruit, but only mix your fruit with fruit, not with anything else. Have oranges, not orange juice. Have grapes, not raisins. I'm actually going to record to get smart and record that one of these days and just start pushing the play button on the tape player. Nuts and seeds cause spastic or open ileocecal valve, one or the other. Popcorn, chips, nuts, and seeds. It's okay to eat corn as long as you're not sensitive to it. Corn's no problem, but not popcorn. Do I ever eat popcorn? Yeah, but about 3 or 4 times a year. If I go to a movie I really want to see, I'll get it with lots of butter on it and watch the movie. But not that often. Maybe 3 or 4 times a year, maybe. And only a really good movie. If I want to wreck myself, it's going to be over something good, you know? Okay? Any questions? This is a biggie. Ileocecal valve is huge. It's one of the things that I check on every patient, every visit. Yeah. Quadratus lumborum is related to the appendix, which we haven't covered yet in this year. But the ones that are definitely related are, what I want you to know is iliacus to the open, quads to the closed. That's what I want you to know. Ileocecal valve is so important. When we talk about category 3 in disc in session 4, 4, you're going to hear me say, iliosacral valve, iliosacral valve, iliosacral valve. Because it's that important. I want to pound it into your head. So when you get a hot disc patient, check iliosacral valve. One of the things about a hot disc patient, if they're a new patient and they don't know you or your abilities, is you want to show them that you know what you're doing, that you're going to be able to help them because they're getting input from who knows where. And people are telling them to go to an orthopedic surgeon or go to a physical therapist or whatever. Just test the iliacus in the prone position before you treat them. It'll be weak on one or both sides. And then after you treat them, it'll be strong. So tell them that if you can strengthen that weak muscle by the end of their treatment today, there's a very good chance, more than likely, that you're going to be able to help them. And of course, by the end of the treatment, the iliacus will walk. So it puts in their mind, oh, okay, he knows or she knows what they're doing, and they're going to be able to help me. Anything else? Iliosacral valve. It's huge. I personally check it on every patient, every visit. Yeah. Zymex 2. Oh, to decide doses. It's arbitrary. It's arbitrary. 9 a day is a good in between. You're going to get, now if he weighed maybe 300 pounds, I might tell him 15 a day. But 9 a day is usually about average. Now, there's a mirror image to the iliosacral valve on the other side of the body called the valves of Houston. It has nothing to do with Texas. Okay? So here we have iliosacral valve on the right. Valve of Houston is on the left. You should also check that because sometimes it won't show here. It'll show here. Now, how do you treat it on the left? Same as you would on the right, but you're going to pull up and hold towards the right shoulder. You're going to push down and out to the left hip. The reflexes are the same, except they're going to be on the other side of the body. So it'll be C2, C3 here, bicipital tendon here, below the left ASIS. It'll be the left kidney 5, right bladder 58. Okay, so same reflexes, but they're on the left side of the body now. It's still C5L1. Okay? Any questions? Iliosacral valve. Got it? You're going to workshop it tomorrow. Okay, we're going to do that with the retrograde lymphatic technique. And I think what we'll do is, I know we're scheduled until 6:15, but I think what we'll do is let you out at 6 o'clock, and then we'll go over the retrograde tomorrow. We'll workshop those two first thing in the morning. Iliosacral valve and retrograde. Do yourselves a favor, check that on every patient, every visit, both on the right for the iliosacral valve, on the left for the valves of Houston. Also, we got 7 minutes. This might be important if you listen up. It may not show the supine position. It may not show in the supine position. Let me just say it a third time. It may not show in the supine position. So you may have to check it right side down, left side down, prone, seated, or standing, just like you will for the TMJ. So it may not show in the supine position. It may show only in a weight-bearing position, or prone, or right ear or left ear down. So if it doesn't show supine, don't assume they don't have it, because they may have it in a different position. Carl, would you come up? Land your back with your head up here. Feet down there, body in between. Hands down by your side. Bring this knee up. Bend it. Carl, you push up, I push down. Okay? And one up. No. No. Don't push. Push up. Doesn't show, right? It didn't show. Let's try the valve of Houston. Who wasn't doing that earlier? Okay, hold this up here. Push up. It doesn't show, right? Therefore, he doesn't have it. Are you sure? Are you sure? Come on up. Face that way. Scoot towards me this way. Bring this knee up. Bring it down just a little bit. Push up. Okay. Let's TL here. And TL here. Push up. Why do you think I tell you certain things? To entertain you? Sometimes. Okay, but not in this case. Okay? So he does have it, it just didn't show what? It didn't show in the supine position. Truth withstands time. Every truth passes through 3 stages. In the first, it is ridiculed. In the second, it's opposed. In the third, it's regarded as self-evident. Okay. I'm AK, you're AK? Okay. Now, we're going to start at 9 in the morning. And as a tradition, what we tried to do, which is what we normally try to do, is we try to get hors d'oeuvres and get a room either here or at the Westin. And we couldn't get, you'll know when you walk out of here, there's a big, big party going to happen here tonight. Not us, unfortunately. But normally we get a room and I get hors d'oeuvres for everybody and we have a no-host bar. We couldn't do that this year because of the, apparently there's a huge party going to be tonight. So what I'm going to do is, whoever wants to, is I will meet you at the bar at the Westin. They're expecting us. And I will buy the first round for everybody. Maybe not King Louis the 13th, but within reason, anything you want, that's my way of giving you some Christmas cheer. All right, Merry Christmas, and we'll see you either in the morning or at the bar.